And we're live on the fourth edition of the Regenerative podcast. With us today, I have a very special guest, a good friend of mine who I've known for a very long time. I met Dan Gould, back actually at UCLA. I might have known you even way back then. So he did his undergrad at UCLA and then Rice for his PhD in bioengineering. And then he went to Baylor, where he got his MD and PhD. He then went to USC, where he got his plastic surgery. What'd you do there? Plastic surgery residency? Yeah. Plastic and reconstructive surgery. Then he went on to train with Grant Stevens and Dr. Calvert. Where?
It's a combined program that's now called the LA Aesthetic Fellowship, but it was a USC sponsored aesthetic fellowship, top cosmetic kind of fellowship
in the country for cosmetic surgery for training. And then now he's practicing private practice in Marina del Rey, still affiliated with certain academic institutions as well, right?
Yeah, I'm still with Cedars. Actually, my practice is now 100% in Beverly Hills. So I've been out of the Marina practice for about 3 years and kind of developed my own office and my own setting. So, it's been a wild ride. And yeah, we met at USC in residency.
That's when we first met. I just heard stories about you from way before.
Yep. But we spent most time together, I'd say, during residency, where we were training together at the program at LA County, doing combination cases for reconstruct. I'm okay for now. Yeah. Doing reconstructive cases together and kind of pushing the boundaries of our programs to improve care for patients.
Yeah, what kind of boundaries did you push over there? You were kind of a boundary pushing kind of guy, right?
Well,
you came in and you're telling people what to do and saying, "Excuse me, sir, Dan Gould, PhD here. I know how to reconstruct this. At least let's review the literature first, folks, and then why don't you tell me what the best option is?"
Honestly,
you were that kind of guy.
Honestly, I feel like it was more than that, because I feel like at the time that we were training, there was a core group of residents that were really different and ambitious and thoughtful in their procedure and their protocol.
You could call them leaders.
There were leaders.
Good leadership.
I really think that. I think in the orthopedic class, in the urology group, in the cardiac surgery group, and in our group in plastics, there were people that were like kind of saying, "Hey, we're going to take advantage of the training environment. We're going to do research. We're going to improve outcomes, not just for our patients, but for patients in the future." And we did that.
Amazing.
I mean, we did things like, if you look at what our classes did in those years, my program had never seen the productivity that we developed, in terms of publications and research and kind of rolling that out. And I think orthopedics as well, it was this combined synergistic approach to research to really improve patient care.
And that was at USC, right?
Yeah.
As a resident.
Yeah.
That's very ambitious as a resident. I mean, generally people so just to kind of define what residency training is. So I did orthopedic surgery residency. Mm-hmm. And that's when I met you. You did plastic surgery residency, and you did a combined program where you were already an MD out of medical school.
Right.
But you couldn't go practice medicine quite yet, right? Because you weren't licensed. So then how many years did you do in training as a resident at USC?
So as a resident, it's a 6-year program. Many combined or integrated programs are between 6 and 8 years, depending on the research qualifications. A good portion of the early part of that is learning general surgery and doing all other surgical disciplines, neurosurgery, ENT, cardiac, vascular surgery. And then you go on to do plastic surgery, where you're doing reconstructive surgery. And that involves everything from pediatric surgery to hand surgery to microsurgery, burn surgery, reconstructive surgeries that are designed for wounds like ulcers, pressure ulcers, reconstructive surgeries that are focused on cancer, breast surgery, breast reconstruction, oral head and neck cancer, other surgical procedures that are really collaborative procedures with general surgery, neurosurgery, cardiac surgery, orthopedic quite a bit. So the training for plastics is diverse. We operate from the head to the toes.
Tell me more about what your county training was like. So when did you start getting in there and operating? Because when you say operating, you know, it's always progressive, right? And I was joking earlier, obviously, about, how your attitude is, but it's really, your attitude is like that coming in because you question everything, and you're a scientist, right? You consider yourself a scientist.
100%.
Absolutely,
I mean, I think on paper I'm a scientist.
Yeah, you are.
Over 150 peer-reviewed publications, editor of a journal, that makes you a scientist. But I would say what you're actually alluding to is a question that I asked myself recently, which is, what makes a good surgeon? What makes somebody who is actually making a difference in their patients' lives and is actually adding to the specialty as opposed to taking from it? And
you had an insight on that very early, I think, right? Because you were critical early about outcomes. You were looking at outcomes as a resident.
100%. We both were. We all were at that time. And
I was?
100%. Yeah, you were doing studies to look at like flaps and shoulder reconstruction as a freaking second year resident. So, I mean, I think that there are people that early on, I think in medical school or maybe undergrad is when you define yourself as like, as a person. Hey, am I somebody who's cool with status quo, or am I somebody who wants to ask another question?
Ooh, I think that's a really nice way to put it. I learned that early on as well.
Right?
You got to define yourself. I defined myself halfway through my first year of medical school.
And then because you could just lay back and whatever. But I did similarly, and I had mentors that pushed me in medical school that asked me that question. They said, are you just going to like, pass by, or do you want to do the best you can do? Do you want to show people what you can do? And I think that your whole life, a lot of people that are in medical school, their whole life, they're not working that hard until they get to medical school. And then they can make
can cruise to a certain extent and be at the top of the class.
Yeah.
And some people are
be smart.
Right?
Yeah. And you can just do
or they
well
play the
on
game
tests.
Right. You can kind of cruise by.
But then you hit that point where it's like, we're about to hit you with a real knowledge gap. And you can either sit here and
somebody's
learn.
life might depend on it.
Someone's life will depend on it,
right.
Inevitably.
Absolutely.
Or the quality of their care will depend on it, or
complication.
Something will happen. And if you prepare yourself now, you'll be ready later. Or you can just go to Barry's and drink your Starbucks and relax, right? And I think that's what defines you in that early time point. So early on, both you and I think, had that realization. And then in residency, you get the opportunity to apply that. Now, nowadays, the training is all messed up because nowadays there's this pushback on autonomy. And when I was in medical school, I was
because of liability,
but also expectations and transparency. When I was in medical school at Baylor College of Medicine, even as a second year medical student, we were allowed to assist in surgery. We had paper charts. So a critical role on the team for me was to show up in the surgery rotation, get a cart, pull the charts, put them on the cart, write the notes, and stamp them with the resident note. Then when the residents were operating, I had to go and they'd say, we need to do this order. And I would go back and stamp with their stamp or sign for them. That creates trust. The harder you work, the better you are at it, the more trust.
Physical movement.
We
all got to do it
then
together.
Trust leads to surgery.
Together.
The other medical student was on the team. She wanted to do pediatrics. She said, I don't want to do any more of these lap choles. I scrubbed in on like 46 lap choles in 1 month period. And I stayed in the hospital every other night.
You and I started the same year, didn't we?
Yeah, 100%.
Yeah, we were interns together.
100%.
That's when I met you, for sure.
100%. It was when we were on ACL. It was when we were on ACS.
Yeah.
And
ACS is acute care surgery at the county. LA
Exactly.
County, right?
I was team D. You were team C. I think Sam was A and Jesse was
Sam
B.
bottles.
Exactly. Sami. But let me get back to this concept that, if you're
shout out to Sam Bottles.
Yeah, he's out there right now. He's
out there.
He's on the East Coast. He's doing
urologist,
great.
Right?
Yeah,
East Coast urologist.
Yeah,
man, we had a bunch of stunners. Just
we had a great
all-star
class.
team. Heckman and Nicholson.
Everybody.
These guys are academic surgeons, and they're creating new pathways in the field. And these are guys we did training
They're
with.
not just academic surgeons; they're actually good surgeons, right? Because this is what we're talking about: is that cutting edge. So, what makes somebody good?
Yeah.
You're a resident. Your second year, you're saying, "Hey, I want to know more." You have the autonomy in medical school.
So we'll say attitude. Attitude's a big part of making a good surgeon.
And autonomy.
Autonomy.
So, as a resident, when we were on, you could time out a case as a second year resident. When you and I were training.
So autonomy and training.
Yes.
That's what, okay.
You're holding the knife. Right?
Yeah.
So that didn't, after we left, like when we became
you got to hold the knife, you got to go.
Yeah.
Somebody can be there watching you.
Right.
Over your back and ready to say, hey, I'll take that,
but
please.
By the time
you got to do it.
By the time we were chiefs, 5s and 6s, that was gone.
We were teaching people.
Right. But that was gone.
Oh, remember, it was starting to fade away.
The 2s could no longer time out when we were chiefs.
Right.
And then fellows were required.
I think that goes in waves though, Dan, because, the way I teach my residents is there's a lot of autonomy, which means autonomy with me right over them. And it just means that it's a different way to learn and it's a different way to teach. And I have a hybrid model for myself because I started working with residents right away who are third years, and they kind of expect to be able to do something.
Yeah, but you come from the training where you had it.
Right.
That's why
But that's why I'm saying there's still people out there.
That's
why as long as my training continues to teach people that way, they will then propagate that to their training.
My argument,
stay within it, but it may be dwindling.
I agree. My argument is not that you don't have it. My argument is that across the country.
But some people train that way and then they don't teach that way. And
I'm probably like that.
That's almost like having kids and then, you don't have any more kids, but then you want to say like, oh yeah, there may be other ways to do that, but you still have to have those channels, like, foster some kids and then you have kids. Like, so then assess what worked for you. And if you're going to be a teacher, you have to know how you learned and what the teachers influenced you and how they taught you well, because there's good, I say this, there's good teachers and there's good learners.
Yeah.
Good learners can learn from anybody. They'll learn something, like even like that guy's so terrible, but maybe because he's so bad, people respond in a weird way. So I learned something from that. Right. But like you can learn from that. And then good teachers will teach a bad student and they'll just kind of make sure they learn at least something. They're not going to be an all-star, but if you have a good teacher and a good learner and you put them together, that's kind of where I think a lot of this was at USC.
I agree.
There was a lot of relationships like that.
Yeah. But like you said, there was also a unique and diverse educational environment with a lot of people that were really pushing the realms, the boundaries. So we had great neurosurgery residents, great urology residents, great, and it was like a unique mixture, because I feel like that was a special moment in time when, if you looked around at the residency training programs, there were a lot of very strong people that had chosen USC because of its autonomy. They had sought it out for the county and had sought it out for that unique environment where they were going to learn and do. And they were really the top of their class because it was very competitive that year for many of the programs. So I would just say that's why the culture was created. And then
that is true. I did select them
100%.
Over several higher ranked programs.
Me too.
Yeah.
I mean, I interviewed at 28 different residency programs.
And I was shocked to see you there, Dan Gould, MD, PhD, because I heard stories about you flying on airplanes and then talking to people about your medical expertise and your research background. By the time you got into residency, you had published, 100 papers or something? Like
it was a lot.
Maybe sub 100, but pretty close.
I mean, that's part of the deal. That's part of the deal.
Yeah. But we learned a lot from you. I learned research from you and just kind of like how to conduct yourself when you have a question, a research question, like what you're capable of. Nate Heckman taught me that too. He is somebody who's incredible because he came up kind of, above the middle of the class, but he was somebody who's kind of top of the class in medical school, and then kind of showed his interest. Really cool guy. And then he started just taking off in medical school residency when he got into orthopedics. Yep. He was doing shoulder surgery research, and thank God he went into hip and knee reconstruction, because I don't know if I would have got my fellowship because he was in my year. He was incredibly outstanding, and I did a lot too. And, that goes to show just the kind of class that we had, because we didn't ever have any kind of competitiveness to each other.
Well, when you're at the top,
exactly.
When you're the top 10%, you're collaborating. You're not competing.
Let's talk about study ideas. And that's what this show is about too, is like, let's get the top people who, can show up in pajamas and hang out and, talk about the things that interest you and ways to make things better. Because, I have a lot of ideas. I wrote them a lot on the board, about things that I want to talk about, because there's these critical concepts, I think, with like tissue healing, peptides, regenerative medicine, tissue engineering. These are complex topics that they start spinning around in my head, and my patients start asking me about them. I do shoulder surgery. I'm a shoulder specialist as an orthopedic surgeon. You're a plastic surgeon. You're a cosmetic surgeon. You're a specialist at these things, at tissue management, and you've done extensive research in bioengineering and tissue engineering, and these kind of concepts. They sound very similar and definitely sound like smart people say them. But what I think is relevant is there's all these new people coming out too, talking about anti-aging, talking about collagen and peptides and like what we should be using. So now maybe we can kind of define some of these terms, because these are things that you know a lot about. And this is stuff that, you have test tubes and you have to understand what reagents mix together to get these types of assays. I mean, these are like biochemistry basics, just to understand the terms. But you got to understand biochemistry to a certain extent, at least the terms, right?
And engineering. So my qualifier is my PhD is in bioengineering, and the PhD I studied was focused on tissue engineering. So we focused on creating scaffolds and loading them with basically growth factors.
What does a scaffold mean?
A scaffold is the structure that you will build the tissue upon. So a scaffold can be biodegradable,
like a lattice.
Or lattice work of biodegradable and biocompatible materials, such that you can put it into the human body in an environment where it will foster the growth of new tissues.
So it'll grow in, but it won't reject.
The body will not reject it because it's made of a material that is compatible.
Got it.
So my PhD was focused on how do we create new brain, new heart, new liver, new lungs, new kidneys. Well, first step is get cells, put them into the body, and get them blood supply. So a lot of my focus was on PDGF, FGF, and VEGF as growth factors for angiogenesis.
Those are all different types of growth factors.
Growth factors that stimulate the body to grow new blood vessels.
That we normally have in our body too. Right?
That our body produces in wound healing responses and in other situations like like cancer in order to increase the blood supply to tissues. And
so tissue healing and response
wound
to
healing,
injury.
and that's the name of the game. That's why I chose plastic surgery, because my background was tissue engineering. It fit well with reconstructive surgery.
Tissue injury meaning either you got hurt and scraped, or something broke down because there's like you said, a tumor, and it just is destroyed. It's necrotic. The cells died. Or surgery, right? Like
surgery,
cutting into
100%.
the body, because that's tissue.
So now there's huge overlap with what I did and the aesthetic space. In fact, I'm involved in consulting and basically a couple different companies that are focused on tissue engineering. One to recreate breast. One that's more of a company that's focused on wound healing to improve aesthetics, because wound healing responses improve skin quality by growing new skin. And other companies that are involved in just the aesthetic space in general. I'm involved in a few tech companies that use crowdsourcing to look at the aesthetic outcomes and improve the quality of care.
I wanted to ask you about crowdsourcing.
I can talk about that in a bit.
Sure. That's a whole separate topic, right?
Yeah, we go in depth on that. Yeah, a lot of what you said is tissue handling. A lot of cosmetic and aesthetic surgery is improving outcomes. So I've really drilled down in my practice on the key perioperative interventions that improve healing, that improve outcomes, and that improve patient care. Because patients come to me not just for a surgical intervention, but for a good result. And a good result sometimes is, a perioperative management. So. Okay, so a good result sometimes focuses on not just those things, but also perioperative management and kind of the things that you do, the experience, not just the surgery itself. So
perioperative management, meaning like after the surgery, before the surgery?
Both before and after. So nutrition supplementation for before surgery to improve quality of outcomes. There's 2 products that I use. One of them is called HealFast. It's like an oral medication that's been vetted by physicians.
You use as a surgeon, you recommend it for your patients?
Yeah, before and after.
So tell us about that and how it works and how you recommend using it.
Well,
what's it called again?
It's called HealFast, but it's basically a product where we have 20 or 30 surgeons sitting in a room, validating the science, looking at every possible supplement that's been shown to improve surgical outcomes before and after surgery. And then we have this kind of process of like deciding whether or not we're going to put it in, and then we okay it, and then we put it into the supplement. So for instance,
you designed it?
I was part of the team. Yeah.
I
so
see.
like I don't get paid right now for the product. I use the product, and there's a small percentage that we get when we sell the product, but I have no royalties or, shareholder value in that company.
Have you heard of XR?
I've heard of XR.
Yeah.
I like that product as well.
Similar.
Very similar.
Yeah, I'm going to have them on the show.
It's perfect. There's like 3 or 4 great companies.
Accelerated recovery.
Exactly.
Right?
And they're focusing on...
I used it for my own surgery.
It's amazing.
It helped with my pain.
Yeah.
I'm still recovering to a certain extent. And when I have pain, I think part of the pain pathways have to do with inadequate nutrition.
100%. There are many studies that have shown that... there are many studies that have shown that nutrition supplementation reduces pain after surgery.
Dan Gould knows XR works to reduce pain.
Not just XR. Any nutrition supplementation
It's inadequate nutrition, and your body needs extra it's upregulating its healing capacity, but it needs additional
in particular
input, right?
The data around B vitamins is the best because
vitamins.
Well, B vitamins because of the peripheral neuropathies that occur.
B6,
B6 and 12, yeah.
B12.
Because those are critical regulators of nerve growth and regeneration. We know that you can have subacute combined degeneration if you don't have enough B vitamins. You can lose the nerve signals in your body. We know that B vitamin is a limiting reagent for nerve regeneration.
Yeah, because it's a cofactor, right?
So I inject it surgically. It's part of my injection routine.
Okay, and you do that topically.
Inject it. Locally.
What about I was going to ask you about collagen, and I was also going to ask you about
Juven.
zinc, and I was also going to ask you about these other cofactors.
So Juven is a product created by a company called Abbott Global Pharmaceutical. They make
Abbott,
they make everything, pediatric formula, everything. So there's a product called Juven that has been clinically shown to improve wound healing in many different situations. That's what I use in my practice because it contains collagen, zinc, other micronutrients, but also HMB, which is a precursor for growth hormone and a valuable contributor to wound healing.
Hydroxymethylbutyrate.
Exactly.
Yeah, and the other thing I was going to ask you about was the fatty acids, so free fatty acids, and what length chain fatty acids, if those are important, such as medium chain triglycerides versus things like fish oils, omega-3 fatty acid chains.
I'm careful with the fish oils because
is there a difference
risk.
or is there any kind of role with
I think
muscle recovery?
I think MCTs are important, but like I'm looking more at collagen synthesis and fascial regeneration.
They're not as important for collagen because there's not really much fat in collagen.
100%. And I'm not looking at muscle often. because, I'm not a muscle surgeon, right? I'm mostly a fascial surgeon.
You're all about that collagen.
Exactly.
Type 1 collagen.
Type
baby.
1, type
you
3.
You love it.
You know
Type
what I
1's the
love
best,
more
though.
than collagen?
What?
Elastin.
Elastin's nice.
Elastin, because you
Elastin's
stop
nice.
making it at the age of 22.
Tell me about elastin.
Elastin is...
That's the connector between...
It's the rubber band.
Yeah, it sticks.
Collagen is the rebar, but you want the rubber band.
I'm going to find a little... Do you have any idea of...
It's a single helix as opposed to a triple helix.
I love this stuff.
And elastin is more complex. It really is the slinky or the rubber band of the skin. It's the thing that we need the most, that we lose the most of. You can have great collagen in your skin and it still just stretches. It doesn't, or it resists stretch, but it doesn't bounce. It doesn't respond. It's not soft. Elastin really is the king of skin and skin regeneration. So that's the piece that gets missed. And there's actually companies now that have products that are designed to improve elastin composition of your skin. So there's one company called Elastin with an A that is a topical medication that's designed to penetrate your skin and stimulate the production of elastin, which is a game changer because we want to have elastin. We want to have the stretchiness in our skin.
So I'm showing a diagram right now,
Yep.
collagen fibers. So this is the structure.
A
so if you
triple
look
helix,
at
alpha
each
chains.
one of these little chains, maybe this is like a tendon, so it's a large tendon, and then they're cutting it down to each one of these little fibers that have these little bundles, and then that way they're arranged in different orientations. So then what we're talking about is collagen. So then can you kind of explain what the helix right here and what they're showing and what the amino acids have to do with this?
Right. So this is a triple helix, which is wound very closely together, and there's some important concept that the chains of the triple helix intertwine with each other, but each chain has its own kind of kinky little helix within itself, where you have
that way it wraps, right?
Right, where you have glycosylation, you have the pro-collagen binding upon itself with intermediate kind of filaments. Also, you got to understand that the hydroxylation of the collagen is really the most important concept.
What does that mean? Those are the little OHs, right?
Exactly.
Hydroxyl groups on the side.
And
that makes it sticky so it can interact, right?
That makes it interact appropriately. And that depends on vitamin C, right? Because we know about...
That's what I wanted to get to.
Scurvy and other kind of diseases where if you're lacking vitamin C, you don't get good collagen synthesis. We also know that vitamin D is important for other aspects of collagen synthesis, but vitamin C is the most important kind of for hydroxylation of the collagen.
Do you know about this? Is this what the structure kind of elastin?
Yeah, this is so this is how elastin works in your skin, but you see how it shows a single elastin molecule, which is this long kind of like a single helix, which is kind of kinky and gooey.
You like that word, don't you?
It's kinky and gooey,
but it works.
And then you see how an elastic fiber can go through stretch and relaxation, and see how when it's being stretched, everything kind of pushes together, kind of. But
it's then like is it like a spring?
It's a spring.
So it loads.
It loads and it unloads, and a spring works two ways.
Very cool.
Right, a spring can be stretched or can be compressed. It's like a slinky; it can be compressed or stretched.
Either way, it'll give pushback or
respond
pullback.
Back.
It'll
so
respond, yeah.
it responds and it responds to deformation like creep. So it doesn't. It's what makes the difference between the skin stretching out and not stretching out in the process of deformation. So having it in the skin reduces the amount of creep that the skin experiences, which is if you apply deformation over time, you get stretch in the material.
Interesting. So then, and you're a big fan of elastin. What is, so how is it made? Is it like amino acids? Do you know?
Yeah, no. I mean, elastin is formed, as
it's like it's this molecule that has like that's what I'm curious about.
It's a single chain, as opposed to a triple chain, and so it's not hydroxylated, so it doesn't kink back on itself as often as collagen. But elastin.
So you would say it's a similar kind of structure with amino acid building, or are they amino acid building blocks, or these are non-amino acids?
Yeah, they're amino acid building blocks.
Okay.
Yeah. But I would just say that when you think about the difference between the two, the main concept is, rebar versus a spring. That's all you really need to understand. And then the production of elastin is limited. Collagen can go throughout your life, but elastin, if you can stimulate the growth of elastin, you can see some big important effects of that.
So for people listening that are interested, so you would say elastin's a big deal. So elastin and collagen. So maybe number one elastin, number two collagen.
Number one.
So for skin, but also would you say for musculoskeletal health, or can you comment on that?
For musculoskeletal health, it's less important because skin is deformational, whereas tendons, you really don't want them to deform.
I would agree with that, and I don't think there's as much that people can do to supplement their elastin for their joints.
No.
But tell us about what people
Joints
can
are
do
less
for their
important.
skin.
You know, joints, elastin's less important. There's glycosaminoglycans, there's
Right.
all those other medications that you can take
and those
for joints.
would you say it's similar to that type of an effect with how the supplements for the joints affect the elastin or collagen in your skin?
Yeah, I would say pretty similar. But I mean, I think the main concept here is that the building blocks are important. Your skin, as we age, loses the critical kind of building blocks. You want to make sure that you maintain those. And if your body stops making them, that's a big deal. So there are topical...
And how could that happen?
Well, as we age, we go through senescence, and our cells stop
Less
producing.
turnover.
Yeah, they stop producing those critical building blocks because we're supposed to be born and then grow up until the age we sprout our first pubic hair, right? We go to the point where we're ready to mate. We find a mate, we have a baby, we're supposed to die. So most humans are not supposed to be here after the age of 20.
So we are supposed to be born and we are supposed to die.
Yeah,
that was one of my big questions.
We're supposed to be born and we're supposed to die.
We
were born 100%. We satisfied that aspect of life, but yeah, we're supposed to die. And so, I mean, people now are arguing.
Did you know that you were not here a lot longer than you've been here?
Yes.
And that you're going to not be here a lot longer than you have been?
It's only a blink of an eye.
Right?
Yeah. And I've been attending a lot of these
crazy.
Don't Die summits and the anti-aging summits and what they're...
That's what I want to know, because a lot of people want to slow or stop aging. They want to maybe live,
you can.
Not forever, but some people might, but they just at least want to slow it down. Let me live longer for better years.
I just want to live better.
How do you do that?
I just want to live better. Yeah. I don't necessarily think that we're going to live longer. Maybe you get to 100, that's great. But I just want to live better. So, I want to be in my peak for longer.
I could go to your Instagram and find the Dr. Gould's top 10 tips on elastin and collagen, but what would you say are the top 3 ways somebody can start right now and have improvement in preventing degradation of collagen and elastin for the rest of their life, for ways that they could maybe alter their life?
This is so controversial, and I don't understand why.
There's not straightforward answers.
This is straightforward, but it's just there are a lot of people arguing that don't know what they're talking about. Misinformation around collagen supplementation. There's this for whatever reason, there's this stream of dermatologists and plastic surgeons and primary care and gastroenterologists saying that consumed oral collagen doesn't matter.
They are against supplements.
I don't understand why.
There's a controversy against supplements.
There are systematic reviews and meta-analysis, 2021, 2022, 2023, all years, all of them published in great journals saying that definitively oral collagen supplementation improves skin quality at 60 and 90 days, period. End of story.
How much should you take? How much, a scoop a day?
It's supposed to be 21 grams is kind of typical dose for a 70 to 100 kilogram person, but the bioavailable collagen is important too. And if you
meat?
Yeah.
If you get a big meat steak,
that should satisfy. But I take additional collagen supplementation because it's not every day that I'm eating enough, animal derived collagen.
Your skin looks great too.
Well, thank you. I've been eating a lot of collagen.
I'm going to start eating more collagen.
I don't use anything topically. Yeah. It's all what I eat and working
whenever.
out. Yep, 100%. And a little bit of bagels to keep the fat in the face.
I like the bagels,
you know what I mean?
too.
You got to keep the fat in the face.
You got to stay filled out a little bit.
But
especially as you get older, because if you get too skinny, you risk hip fracture too. So,
exactly.
You got to keep the joints loaded, but you got to keep your heart healthy. I mean, there's a balance for all these things, but people always say balance, moderation, balance, moderation. What does that mean? Does that mean I can go crazy once in a while? Or does that mean I can kind of go a little crazy every now and then, every day?
I think what does that mean? No, listen, I disagree with that concept. But
I do too. I think you just got to take care of yourself.
No. I disagree. I disagree with moderation.
Oh, so
I disagree with moderation.
With what?
People say you can have a cheat day on your diet.
Let's go wild.
You can't do that. You can't do that. You know why?
It disrupts.
Your pattern.
It's about timing.
Humans are creatures of pattern.
Hack your biochemistry.
And why would you? And then when you do that, it's why would you subject yourself to that torture? Why not just change yourself? Why not just change change it completely?
Yeah. Change your behavior.
Change your behavior.
Alter it in small steps.
Because humans
that are manageable.
The thing that separates us from animals is our brains control us.
Take this for example. Stop smoking. I smoke every day. I'm smoking cigarettes. That's what I do. You need to quit because you might get lung cancer, but I'm 25. Why do I need to quit? Okay,
not just lung cancer.
Right. So we'll talk about all the complications but let's agree that people know there's complications. But if I just have 1 or 2 or a pack and then it's over time, it's they're not going to quit. They have no reason to until they get lung cancer and then it's too late. So tell me this behavioral story. Whenever we have a patient that comes in for surgery and they're a moderate smoker, maybe even a heavy smoker sometimes, or they're using nicotine in some way on a regular basis, and you say, did you know that if you're a smoker and I'm going to do your surgery, that you're nearly guaranteed to have a complication, wound issue.
I don't operate on smokers.
Exactly.
I don't do it. I just say no.
Exactly. So then what does it take to get that person to change their mind to have surgery from you? A discussion, right?
Yeah.
Hey, you need to understand that if you are going to continue to smoke, I will not operate on you because of the extremely high risk of these complications. And we've all seen it. A lot of times it's from people that don't, they don't make it as known that they're actually doing this type of behavior.
They're lying.
But they're basically lying, maybe
Yeah.
to themselves. And let's say that we have this open conversation where they do understand there are significant risks.
And I have a
involved in
special
that.
consent. I have everyone sign that
Sure.
says, I acknowledge if I am a smoker that
every
Dr. Gould will
surgeon's-
not operate on me.
Every surgeon should consider if their patient is smoking. It's, tissue toxicity, and it can increase wound complications.
And
with any kind
nowadays
of
we have
surgery.
other problems.
But-
we have
but
vaping,
yeah.
we have, Zins,
So
we
it's
have all
nicotine,
kinds of nicotine.
especially nicotine. So let's say that there's a clear pathway towards that. I have gotten people to stop smoking because of surgery.
Me too.
Haven't you?
Yeah, 100%.
Absolutely. Because it's a behavioral change where they can say, I didn't realize that if I realize smoking is harmful. People mostly know that, but they don't understand how it is a non-union generator for orthopedic surgery, for any bone surgery, because it inhibits bone growth and the bones just stay like this.
Yeah.
The bone cells don't move at all. You're smoking every day. It's like no blood flow. No cells are moving. Your tissues are not healing. It's hypoxic when it needs to be hypervascular. You need to be getting all this XR nutrition, all this creatine to your muscles. And then you're
Nothing's
not getting
being delivered.
Exactly.
Yeah.
So you're going to have complications. So when people really kind of understand that, maybe this clip will kind of help people understand, don't smoke before or after surgery. What's your rule? My rule is 1 month before, at least at a minimum. It should be 3 to 6 months,
I do 6 weeks.
6 weeks.
I do
a
2
month and a
weeks
half.
in, I test the urine.
Okay.
Urine's positive, we cancel the surgery.
Of
Day
course.
before surgery.
Cotinine or just nicotine?
Cotinine.
Yeah.
The day before, cancel it.
Zero. It has to be zero.
Zero.
Just stop. Zero. You have
Zero.
to stop. And if they can't stop, then test them.
I give them 2 weeks to
Right.
start the stopping process.
Mm-hmm.
And if they haven't stopped it in 2 weeks, we cancel and move their surgery back 6 months and say, good luck.
Some
And
people
if
can
they-
stop. Some
and if-
people can't stop right away, but then they can eventually. And then some people can never stop.
If they're positive the day of, they're going to forfeit their deposit too. So it's a financial thing, and it's great because then they're like,
That's extra incentive.
oh, they're really incentivized. But I would say it's rare because nowadays I don't even enter into the conversation with smokers. I'm like, you're smoking.
Zero.
Can
Sorry.
you stop?
Call me when you're ready.
Yeah, exactly. And
There's
then-
just there's no more conversation.
right? Because it's silly to have the conversation.
Especially
Of the
for
people I've
elective
operated
cosmetics.
on that have been smoking or have lied to me about smoking or have vaped or whatever, it is 100% complication. And then I ask them specifically, are you smoking? And they say no. And I say vape, and they say yes. I say, okay, well, why are you deceiving yourself? You know that this is even worse than smoking, or you know that it's just as bad. And then they say, well, how did you know? I say, because the complication
Because
I'm
I'm a
seeing
wizard.
is common
That's
in
exactly.
Yeah.
That's exactly what I say. I say, why is there
why
a
do you think I
complication
knew?
here?
Yeah, how do you think I
they found
knew?
out? Have you been smoking? Oh, well, just a little bit.
I don't have a crystal ball, but
zero. It has
Yeah.
to be zero. And
Yeah.
so I'm much more critical about that.
But
now.
here's my question for you. If we're so good at intervening in their smoking process,
Well,
how come they haven't heard
moderate.
about it before? How come their doctor before hasn't had the conversation with them? Or why is it that not until they need surgery that now they're like, oh, I didn't know that smoking caused your skin to
because
not
it's a
heal?
pretty significant change in their life that they
Yeah.
have to, injuries happen, like your life continues, but injuries happen.
Yeah.
And, sometimes you need surgery. Sometimes you want surgery.
For
but,
mine, it's they
you know,
want.
they want it, but they might think they need it and they got to do it. And I need it now because I'm going to be on the LA Shoulder podcast where we talk about injuries, soft tissue collagen, disruption, healing, regeneration.
All the things.
All the things, how to make your life better. And then what we were going to get to was the fact that don't smoke because it's bad for you. Right, Max?
Yeah.
Smoking is terrible.
Smoking's bad for you. And so tell me what Grant Stevens was like. How was that relationship?
Grant was great. So my training, I knew Grant from when I was an intern actually at USC, and I met him because he was this kind of prolific figure in cosmetic surgery, but also he was friends with my next door neighbor growing up who was a famous dermatologist, or her name's Suzanne Kilmer. And she reached out to Grant and was like, you got to meet this guy. And he was like, I already met him. He came to my office like 2 weeks ago, because I was just interested in checking out all the different people that were kind of leaders in their specialties within plastics. And then we developed a relationship, and I met all the fellows that he had been training, and he kind of brought me into the concept of aesthetic surgery as like a potential practice.
Is that when did you consider doing cosmetic surgery?
Maybe before? Like my third year of residency was when I was thinking about it.
Yeah, because you had done the tumor research. You're considering
everything. I had done I was microsurgery. It was what I was really interested in. But I had done all kinds of. I was interested in all kinds of different things: craniofacial, micro, hand. And then
was he a figure that influenced your decision to go into cosmetic surgery, aesthetics?
Yeah, for sure. I mean, he kind of showed me a different side of plastic surgery. Some of it good, some of it bad, but it was like a whole different idea of how you want to run your practice. Honestly, when I came out of my residency program and my fellowship, I was still looking at a microsurgery job as like a combo aesthetic micro.
Right.
But that was the middle of kind of like COVID, and so a lot of
you
jobs.
You could take micro call and kind of do complex
we would
cases,
be
right?
doing.
Is that what you meant?
We would be doing reconstructive and transgender microsurgery, which was a hot topic at the time. And we would be doing cosmetic surgery. I would be doing both of those things and teaching residents cosmetic surgery in the academic environment, which is very rare. And I was ready to do that. But then because
Stevens was a professor at USC, right?
Yeah. And he
still is, or is he's retired?
He's retired. He's retired for about 2 years now. But then everything fell apart. There were no jobs. There was nothing that we could do because everyone was worried about what was going to happen with the financial situation after COVID. And then Grant at the time was just like, hey man, if you want to stick around, you can just stick around and eat what you kill. And that turned out being a really great situation because there was a lot of surgery that we did in that period of time after COVID that was cosmetic.
And was Calvert, was he his partner?
Calvert, they're not partners. Calvert has his own practice in Beverly Hills, separate practices. He was part of the fellowship because...
So you trained with both?
Yeah. So there were multiple surgeons that I trained with. There was also Ritu Chopra, who was a really fantastic facelift guy and was just developing his techniques at that time that I was there.
Andrew, for facelift?
Yeah. And he also did a lot of explant surgery. It's really well known for removing implants
revision
and treating
stuff.
BII.
Did you guys have a lot of revisions with him? Or would you say most of the work you did was revisions or primary? Where you had redos?
50-50.
What about Nazarian? Did you work with him at all?
With her, yes. I worked
with her. Sorry.
Dr. Sheila Nazarian.
Sorry, Dr. Nazarian.
So not during fellowship. I worked with her for a year when I finished. So I was 1099 contractor, 4 days a week at Grant's, 1 day a week at Sheila's. So I was doing Beverly Hills practice and Marina practice, just trying different environments. And it was great. Those were both like heavily fed positions where they had a ton of patients and I was able to take advantage of the patient flow. But during fellowship, I also trained with Andrew Orden, who's the guy from the Doctors Show. He's like pretty famous, plastic surgeon, very recognizable. I trained a little bit with Ben Talia. I spent time with him in his practice as he was growing from just doing lip surgery to doing facelift surgery.
What about the guys from Botched?
Paul Nassif. Well, now I'm in the same operating room as him. So he's in room 1, I'm in room 2. Garth Fisher's in room 3. So I see him a lot. And we fire ideas off at each other. He wants to learn more about glands in the deep neck. So he comes to me and sees that, but you
guys would have a great podcast.
I'm sure.
You guys should do a Botched podcast together.
I'm sure.
That'd be a good one. And we're back. Mm-hmm. All right. Just in case I got to make some cuts here and there, but mostly, we're just kind of rolling through. Hey, so, okay. I want to show you this clip. So this is one about stem cells and I want to get some clarification on this and maybe we can kind of talk about.
We should talk about stem cells and exosomes.
Let's talk about that. So I want to have you.
I'd be like, that's bullshit. That's
not
real.
That?
Dude, it is real. And these guys are starting to make money now. Like the top guys are starting to make
this is when he was talking
decent amount of money.
That looks like ESPN for sure. Like that looks like
something. Look, I had Kamara there.
2285 Joe Rogan.
Doesn't Kamara really fucked up knees? Don't ruin his knees, bro.
Yeah.
People to have the same kind of thing them.
So this is when they're talking about injuries, UFC fighters.
They Panama too. Neil Reed.
So like what for
Dr. Neil Reardon, who's really he's written so many books and papers on the benefits
Have you done the
of
stem cells?
I've done a shitload of them. Yeah.
And what is the immediate impact?
Oh, it heals soft tissue way better than anything else that I've ever used before.
So like what, for example, what injury did you have that you felt?
The biggest one, I've talked about it before. I apologize if you heard this before, people. I had a rotator cuff tear, a full-length rotator cuff tear. And went to a doctor, went to the UFC's doctor. They sent me to an orthopedic surgeon.
Partial
looks
width,
at my MRI.
but it goes across.
You can't believe I can do anything.
Partial
he says, I can't believe you can do anything with this shoulder.
Full thickness
you have
tear
a
is
full-length rotator cuff tear.
But he
does all the
stuff
with me.
That you fix with
push
surgery.
down down, push up.
So
and he goes,
it wouldn't
like,
necessarily
you're
be
pretty
astounding
functional.
if some type of
He
PRP or
goes,
stem
I
cells
think
healed
it's
that.
probably because you have a lot of muscle around the joint.
That's
But he goes,
probably
but
true,
you're going to
too.
need surgery. He
Yes,
goes, you
look
could try
at
to
his shoulders,
rehab it, but
huge
you're going to need
deltoids.
surgery. I
He
go,
does-
really gonna need surgery?
he
He goes,
does like
yeah.
80-pound
I go,
kettlebells
am I
overhead.
ruining my shoulder by not having
Weak
surgery?
sauce.
He's
So
like,
he's got big
potentially.
muscles, like big shoulder muscles
You know,
that compensate.
try your best rehab,
Pretty
put it
heavy.
off as
I
much
can't
as you
do
want,
that
but you're
right
going to
now.
need surgery.
Well, right now.
So then I go to Dr. Roddy McGee in Vegas.
You know this
And
guy?
this was
No.
years
never
ago.
heard of him
He's
either, other than
doing
his show.
stem cells with the UFC athletes. He's
Maybe.
a bunch of different people.
I mean,
He's
I
like, well,
believe
we
it.
could try it. And I think the stem cells I got them actually aren't even available anymore because they were too good.
That's
so
why that's why they're not
injected in my
available.
shoulder.
They're too good.
Those are the
The
Panama
FDA
ones,
said
right?
these are
And
too
then
good.
FDA
rehab
said,
it. I'm doing
sorry,
like
guys,
bands
these are
and
working.
all sorts
Yeah,
of different
yeah.
stuff. I get it to the point where it
he's
starts
talked about
feeling
this,
good.
like,
I start
20
light
times.
kettlebells,
Yep.
feeling pretty good. I go back to him 6 months
Story
later.
checks
He
out,
does an
though.
MRI. He says, "This is the most astounding thing I've ever seen in all my years of
It's
being an
healed.
orthopedic surgeon." He goes,
Yeah.
"The tear is gone." Like you just
Maybe
this
what else could
full-length
happen?
rotator cuff tear that
The
was gonna
planes of
need
the cut were a
surgery
little different on
doesn't
the initial
exist.
Different
MRI,
scan.
and maybe
Like when I
they
say like my
overcalled
shoulder
a tear,
is better,
and then maybe now
I mean, it doesn't bother
shows
me
there's
at
no
all.
tear at all because it's
But for
Like,
someone to
long.
say this is the most
I do
astounding thing I've ever
everything.
seen
I
in my
hit the
career.
bag.
Come on. I've seen some really astounding
Real.
things.
Kettlebells with 70
I saw
pounds.
my-
and
Joe
one of my-
Rogan partial tear not being
curls
tear is
and
not
maybe for
astounding.
presses.
You know what would be
He's seen
astounding?
a lot
Arm
of-
grew back.
Not
Arm grew back.
Not
That'd be cool.
one thing like, man, maybe
I
I
saw this
shouldn't
guy
be
with a
doing
missing
this.
head
It like
pop
feels
who had
100%
a skin graft
normal.
over his brain that was
And
working.
all
That's
stem
astounding.
cells.
That was astounding.
Like,
I saw that
I coulda
accounting.
got
That was
cut with
definitely
a
astounding.
sling.
And then you're done.
Didn't do any of that.
But
There's
he's
I
doing
have a
well,
shoulder,
so it's
a little
like
bit of
maybe there's
shoulder
something
issue, actually.
there.
I'm curious
But I
if
think
the
what
stem cells
100%.
Like
I'll bring
to-
you to Ways to Well. That's
I
in
would-
Austin.
you know about that?
Yeah,
Ways to
Listen,
well?
man, they've healed
I'm
so
curious.
many people that I'm friends with.
I had a
I
So
looked
many
this up.
guys that I
There's
know.
no
Like minimal
studies
scapular
that
movement, I think that was the
institution
issue,
has
so I was
performed.
making up for
I don't
the
know.
fact that
Call it
my
institution. It's a
scapula-
business.
Let's get into
There's
it.
no
Yeah,
okay,
let's get into
that's
it.
enough.
Let's get into it. We get the gist.
All right.
So right now there's a lot of misinformation being spread about the use of exosomes and stem cells.
I'll leave that
and-
picture up. That's a good one.
Yeah, it's good. And regenerative medication in general. And the problem is, as a physician,
As a surgeon,
as a surgeon, our job is to help patients decode the minutia, the nonsense,
the podcast.
the podcasts that are out there, because there's a lot of people with great.
Two MDs talking about stem cells right here.
And there's
That's
a
what
lot
you
of
got right here.
That's right, and you got a lot of programs out there that are
Practicing MDs, board certified surgeons
both
who
of us,
actually
you and I,
are at the cutting edge
and that are scientists,
and that are actual
and that
scientists.
understand stem cells.
Practicing.
I mean,
surgeons
that
and scientists.
we
Surgeon
use stem
scientists.
cells a lot in my PhD, so I can tell you from a standpoint of knowledge, okay, that there's a lot of podcasts and people that are out there that are trying to capitalize on the excitement, which is great, around stem cells. And stem cells have been around for a long time. But first thing you need to say is, what is a stem cell,
Yeah, have
and
the
what is
history
the
of them.
source, right? Where do they come from? Because he just said in the podcast, we had these stem cells and they were so good they took them off the market. We can't use them anymore. Where did they come from?
What was that, man?
Right? Like, are you taking stem cells out of someone else, out of an umbilical vein, out of a fetus, out of a human? And what is the source? Because the source of the stem cell is key. Because you can have a pluripotent cell, which is sort of a stem cell, or you can have an embryonic cell, which comes from a child or from a human derived umbilical stem cell,
Or a mesenchymal stem cell.
mesenchymal stem cell,
We use those a
endothelial
lot.
stem cells. There's many different types of stem cells. MSCs are kind of like the ones that people look at the most nowadays.
Orthopedics, definitely. So
And plastics.
Mesenchymal from bone, marrow, adipose, umbilical cord, used in regenerative medicine, it says.
Right. Now, so here's the deal. The reality is that the FDA is careful, and they are trying to say, hey, we don't want people just willy-nilly injecting stem cells, because you could get cancer. You could die. You could have an autoimmune disorder related
Right.
to it.
I'm just going to read this real quick. The only FDA-approved treatments for stem cells, the only HSC transplants. So HSC stands for hemopoietic stem cells. So these
Right.
are bone marrow, cord blood, are FDA-approved.
Right.
Okay. No FDA-approved orthopedic, neurological, or regenerative MSC therapies. So the mesenchymal stem cells. All other uses are experimental or unapproved outside of clinical trials. That's
right.
it.
Now, I
That's
come
it.
from a specialty where we do a lot off-label. Okay, aesthetic surgery. Most of what we do is not
Off-label,
on-label.
meaning FDA has not approved
FDA
it.
has not approved it.
But
Or-
they've approved some use, and so they're using it for other uses.
Right. Now,
Right?
there's
They're using it
different-
for other
And there's a
indications.
difference between, and this is very confusing to the public, FDA cleared, registered, and approved. So a lot of products are FDA registered, meaning, hey, we're talking with the FDA about our product. FDA cleared. The product probably
That just
doesn't
means they submitted it.
we're talking to the FDA about our product. FDA cleared. The product probably doesn't hurt anybody. FDA approved. It definitely has a positive impact on this disease process.
And it's been studied.
Been studied, proved, everyone knows it works. Okay, so FDA approved is a huge barrier. It takes massive amounts of research. Most drugs that are FDA approved are $800 million to get from an idea to a concept and go into a person. FDA cleared, that's very low bar. Basically the lowest bar that you can have. And there are many products that say because of a 510K pathway, it's probably not going to hurt you, but it hasn't been proven that it's going to help you.
Right. Maybe
FDA
it's not gonna
registered,
harm.
you and I can register something with the FDA tomorrow and then say that we have FDA registration. We're
We're working on it, guys.
We
We'll
just
get
sent
to
them a
it.
letter.
Yeah.
We registered with
We
them.
registered, yeah.
We sent them a letter. And they might not have read the letter. It could be acid in this battery acid in this vial, but we sent them a letter. So I think that you have to understand that the consumers are confused because there's not a good amount of kind of education about what these regulatories mean.
So let's clarify then. If somebody says we're going to use actual stem cells, what you may say as a treating provider, what type of stem cells would you say have been studied to an extent that you actually do use them in clinical practice?
I use stem cells every day in my clinical
There
practice.
we go. So let's go into that. What do you use that actually is?
In my
that's been studied?
facelift practice, I do a lift to remove skin, and then I use fat from the patient's body to restore volume. We call that structural fat. And then I use something called nanofat to improve skin quality. Now, if you look at nanofat, and I will tell you, I'm an expert in nanofat because I am the co-chair of the San Diego Advanced Regenerative Therapy Summit, which happens every year. And in that summit, we talk mostly about fat and nanofat.
Why is fat important? Is that because of the mesenchymal stem cell properties?
Because of the adipose-derived stem cells that exist
So
in
you
the
can
fat.
get stem cells from fat, basically.
So nanofat is broken fat cells, stem cells, and growth factors, right?
Yeah, nanofat grafting is an advanced fat transfer technique in plastic surgery.
Yep.
And
we basically harvest fat, we process the fat, and then we inject the fat. But we can actually...
where do you harvest from?
Different
wherever
areas.
there's extra.
Different areas, not just wherever there's extra. There are some areas that have better and higher quality stem cells than others.
Higher yield?
Higher yield, higher concentration. So for instance...
Do you have a proprietary machine that processes the...
Yeah, it's called my right arm. It's proprietary. No, the
Can you patent
devices, the devices that are out there are many, but they're all lame. It's stupid. You just need a 2 millimeter sharp cannula to harvest fat.
Basic technique.
It's not just you need the right technology, but it's not complicated. So there are companies that have created
I shouldn't say basic. It's a straightforward technique that doesn't require advanced technology. Is that
correct?
Right?
You just need a sharp 2 millimeter cannula so that you cut the fat instead of sucking it and ripping it and tearing
So you kind of take it.
You want a sharp connection. So you
don't want it mushed up.
Right.
Basically.
You don't want to create too much.
Sometimes liposuction does that, right?
Well, we're doing liposuction to harvest the fat.
Okay.
But we don't want to have. Yeah, but we don't want to have too high of a negative pressure, and we don't want to have too much avulsion of the fat. We want to have a sharp harvest of the fat, so we rip off the little bits of the fat. But then you take the fat and you pass it through a sieve, and you take the smaller cells that come out after breaking the fat cells, and that's how you get adipose derived. You can also put it in a centrifuge, and you can centrifuge out the higher density cells, and you can get stem cells that way. But the FDA doesn't want us to process those materials too much, so they want it to be minimally manipulated fat for the purposes of safety in surgery.
Right.
And so I tell patients we're going to take the fat out. We're actually all we do is liposuction, put it on a back stand, rinse it with a little bit of normal saline, blot it on a piece of paper to remove liquids, process it by passaging it back and forth a few times to break up the fat and get just stem cells and growth factors, and then pass it through a sieve. So it's a screen that just separates it out, and then we inject it. That's it.
Amazing.
Super, super simple.
What is the yield, and can you quantify it, or is it based on quantity of material? Can you say I have X amount of stem cells, or can you say I have a certain amount of quantity of volume?
Neither. You can say I have a certain amount of nanofat, right? So, and then how much of that volume stays? It actually doesn't depend on what you have. It depends on what you're injecting.
Because it's also
into.
density.
No. This is the biggest mistake in all of fat grafting and cosmetic surgery. Patients say, how much will survive? That's foolish. Okay. The real question is, how much can I put in? Because in a perfect world, each fat cell and stem cell needs a cell next to it to give it oxygen, nutrient, and blood supply.
Yeah, you
if
need
the
a neighbor,
tissue
you need a
is
friend
this
nearby.
thick, it's going to be double.
The scaffold
it's going to be this
concept,
thick.
kind of
right.
what we talked about.
If there's no scaffold, you can put all this. If you have 100 grams,
floats down, gravity.
if you have 100 grams of breast tissue, I can add 100 grams of fat. If you put 400 grams of fat into 100 grams of tissue, only 100 will live. You'll have 300 die. That's a 25% yield. If you put 200 grams in, 50% yield. If you put 100 grams in, 100% yield. It's a very simple equation, and yet everyone gets it wrong. And surgeons are just too lazy to sit there with a patient and explain this concept because it takes a lot of time.
Well, that's why we go to Dan Gould, folks.
When my patients come to me, I say, hey, you want to know the yield? 100% if I do it right.
Yeah.
If I put too much in, it's going to die. You're not going to be happy.
So do you,
but with regards to yield for stem cells,
yeah, exactly.
yes, you can improve the yield.
You can.
But the other concept is that when you're doing grafting of nanofat, it's not a volume replacement. So when I tell patients we're going to use...
It's not a volume replacement.
No, it's not volume.
Okay.
So when I inject into the lips of the tear trough, it's to improve the skin quality. It's to improve the thickness of the skin, the quality of the skin. It makes the dark circles go away because it thickens the skin.
So it's
and
enhancing the tissue.
It enhances the blood flow. I'll show you pictures of patients before and after. You can see their lips.
Do you have
they're
any
pinker
online?
afterwards. Yeah, they're all on my website.
Yeah, pull it up.
But they're pinker in the lip afterwards. There's
Pull it
shine
up,
there.
Mike.
The improvement in the quality of the skin, it's very different. So I think that you have to know that because the nanofat is not designed to improve volume. Structural fat is for volume. That I use. We use living fat cells with stem cells and growth factors, and that's one way to improve volume.
So when somebody comes in and says, I want stem cells versus I think I can help you with stem cells.
No one does that.
So,
no one does
so
that.
It's
People
more
come in and they say, I want to look younger.
Right.
And I say, great, here's my approach. We're going to lift, we're going to add volume, and we're going to use stem cells to improve the quality of your skin.
Okay.
But we don't really say nanofat, and then I talk to them about what
you teach
that
them
means.
how stem cells can help them.
100%.
I see.
Yeah, we have a conversation about it.
Man,
and
that's
I'm
a
not
handsome
marketing
picture.
it as, just go to the gallery. When I go, I'm not marketing it as a stem cell treatment. Go to menu
This one?
at the very top.
Mm-hmm.
Yeah. And then you can go to the gallery.
These are the pretty girls that you fix?
Face.
Man, come to Dan Gould and you will become beautiful. This one?
Yeah, but
This is why I became friends with you, Dan. I knew one day
you knew.
you'd
Scroll
be
up.
on my podcast. This way or this way?
Keep going. Yeah. So you can click on.
Man, this is a nice website.
Yeah, you can click on reset lift. So go back down. Yeah. Reset deep plane facelift.
Right here?
Yep.
Okay.
And then scroll down.
Okay.
You'll see some examples.
Cass wants to talk to you too. So
Yeah.
she's
Happy
like,
to do it.
can't
Keep
have
going.
Dan bring
Okay,
stuff
okay,
over.
here, this is a good one. So here, wait. Go to this lady.
All right.
Okay. I'm going to show you something really cool.
Okay.
Okay.
I love cool stuff. I'm really into cool stuff. So if it's cool, I'm into it. Let's see cool stuff.
Pull this up. Okay. So okay. So I want you to look here, okay? You see her lower lip?
Mm-hmm.
Do you see how before it's cracked and it's not as pink and not as nice, and then afterwards
Oh,
the
yeah.
kind of cracked part to the lip is better?
Yeah, her lower lip.
But also look at her tear trough region right here. You see
Yeah.
there's some hollowing there. Now it's better. Less kind of bluish, less hollow.
Yeah.
These are effects of the fat. Okay, now, of course, there's other things that we did for her, right? Her neck, her
Yeah.
chin, right?
So this is fat grafting.
Yeah. So she had previous, this is facelift and fat grafting.
Facelift
She had
with-
previous facelift. You see her scars here from her previous facelift, which are not great, right? And she's unhappy because they left this guy behind, this
Right.
goober.
Mhm.
And now we've given her a nice chin and jawline and removed a lot of the stigmata of the previous facelift. But also you see her brow points down and now it points lateral. These are little tricks.
Just a lot of little ways
Right.
to improve the face.
Subtle moves that
Right.
make a big difference in her case.
That's what you're a specialist at, is making girls pretty.
Making women
So-
helping women recognize the person they see in the mirror, not
Well-
making them pretty. I don't think of myself as like a beautifier or an artist or any of that bullshit.
But you are.
No, I'm not. I follow the
You are to me.
anatomy. I
you
follow
know,
the anatomy.
Beautiful.
The anatomy.
Anatomy is beautiful.
That's
so you're
what
an
guides
artist.
my process.
You can see,
Mike,
it's
this
like
is the thing that
you can
differentiates.
see the beauty.
This is
underlying
the thing
beauty.
that differentiates me from every other facelift surgeon, even deep plane surgeons. On the inside, when I'm opening, I look at the malar retaining ligament. I see where the ligament is and attaching to the soft tissue. And when I'm closing, I put it back where it belongs, and that's it.
It's beautiful.
Most people pull until they think it looks good.
Get it the way it should look.
Just put it where it was. put it where it was. I
restore.
trust where it was. I trust the roadmap on the inside.
Beautiful statement.
It's
because
anatomic.
It's amazing because I follow the same principles in orthopedic surgery,
Anatomy,
especially shoulder surgery. As a specialist in total joint replacement, you have to be a master of the anatomy in every way, and knowing where all the turns are and the muscle connections and the variable connections, and then how to change that to reconstruct it. And that's what I am doing, is knowing where things should be and seeing that perfect, beautiful anatomy as an artist, because you see that, you're looking at it, and then you know where things should be, and when things are off, you know how to restore it, and then you know if those things are possible or you're capable of restoring that, because then you know what you're limited by, and then if you can go above that or beyond that, or if you have screwed something up, which is so rare. Like if you have an excellent surgeon when you're at the top of the game, I mean, that's not something that we're doing, is like screwing, it's like, that's just, we're looking for exceptional results, and it's like, if we're having a bad day, you don't go in.
Yeah.
And it's like, well, we're ready. I'm ready. And my patients ask me like, how are you feeling this morning? It's like, I'm ready. This is like what I love doing.
I show them my sleep scores.
Ready to
They're
go.
Like, did you sleep last night? Like, yeah, look,
it's like
91,
the greatest,
92.
coolest thing you could be doing right now in the room doing this surgery. And, that's why I wanted to do the show, to talk about these things, because I spent so much time talking to people in the office and kind of saying, like, kind of putting things together and helping people explain things. And I was thinking like biceps tears, rotator cuff tears, and I'm showing them the models, and I'm trying to figure out ways that, I can explain things better. So I've honed that, and I've really learned how to talk to somebody, figure out their diagnosis, and kind of, we both agree, all right, do you want to do surgery? What kind of treatment do you want? And, we start getting to the next steps pretty quickly after one, 15, 20 minute conversation. And so I've gotten to become a pretty good specialist at talking to people about their problems, at least,
that's medicine,
and that's medicine. And obviously you are a specialist at that, and understanding people, because there's a huge mental component, I'm sure, to understanding what people are looking for,
especially
with
for
their
cosmetic
with their own appearance, because that might mean something very different when we talk about making girls pretty again. It's because that can mean so many different things to so many different people. And
but
that
let's
obviously,
let's also say women. It's not girls.
Girls?
Look at my average patient.
Little girls aren't doing surgery.
No, they don't. I'm not a pediatric
Women.
plastic surgeon.
Women.
I would say making women.
Mostly old ladies.
And I wouldn't say old ladies. I would say
Pretty
mature
old ladies.
women.
Yeah.
And I wouldn't say pretty. I would say beautiful, because these are all. This is the world we live in, Mike.
Dude,
okay?
I've just been understanding people better and trying to just like get into what they're about. And I think it's a cool thing to I think when you're a resident, you kind of get overworked, and you see almost patients as just like getting to the end of the day, and because I got so many more things I got to do, and then you start practice and you're just like, I'm avoiding complications, I'm trying to figure my own way out, and then eventually like the older surgeons are like kind of happy, or they're either crotchety or they're pretty happy, and I kind of saw that. It's like, what makes the happy guys happy? We're talking about what makes a good surgeon. I think we kind of got to that. Persistence and being smart kind of helps, but
just asking the right questions,
and being critical, and then that leads you to be maybe a good clinician too, like talking to people. Like you're so good at talking to people, and getting into people's lives, but kind of figuring out like what they're looking for to get out of it. And that's what I'm looking for too. Hey, how can I help you? How can I make your either shoulder better, or do you just need to understand your shoulder problem? Can I help you understand it? So I think with the podcast, we can shed a lot of light on certain things. Stem cells, like what does that really mean? What are the FDA regulations? Let's talk about it, and let's go through things like BPC 151. What the heck is that? Is that a peptide?
Yeah, it's a peptide that comes from.
Are we done
stomach.
talking about this
I don't know,
beautiful lady that you fixed?
Yeah,
she's so beautiful. No, man, the work that you do is so great. I think, working as a plastic surgeon is just the work that you do. It seems like I'm getting better at what I do, but the work that you do, just visually seeing how people like
it's nice that you can see it on the outside.
You can see it.
Nobody's like looking at the tendon repair. They're just like, my arm works.
Yeah, you should better be happy your shoulder works.
Yeah,
I'm happy. You should.
Well,
be happy.
they should be happy, but they don't know. Like they don't see if you put the extra work into like.
And good plastic surgeries, it really changes people's lives.
100%. I mean, it can help them to recognize the person they see in the mirror. It can make them feel more confident. It can make them feel better about their body. Mommy makeovers can actually give them function back, improving core strength, urinary incontinence, sexual dysfunction. So yeah, it improves people's lives.
What's your favorite? What's your favorite surgery to do? I know I have mine, but what's your favorite surgery that you enjoy doing for whatever reason?
I like facial rejuvenation, but I mean, there's two things I'm known for. It's deep plane facelift, the reset lift, and the special tummy tuck, the painless, drainless abdominoplasty, which we now call the reset tuck. But essentially the concept is
Did you help develop that?
That's like my baby. I mean, that's the thing that I've written 8 or 9 scientific articles on that.
Drainless tummy tucks.
Correct. Mm-hmm. Yeah. And I've been doing
Is that what people do now?
More people are doing it now because it's part of the education and curriculum, and The society has kind of adopted it, and now they're starting to kind of say, yeah, this is a good idea. But when I started my practice, I had a lot of people saying, this is crazy, you shouldn't do this.
What gave you the idea for that?
It wasn't my idea. There were guys that were doing this in the 80s and 90s. There was 2 father-son teams in Texas, Antonetti and Antonetti and Pollock, and they were basically in an environment where they were trying to show that they could do drainless abdominoplasty by using quilting sutures on the inside to get rid of the space where fluid could accumulate. And that's really kind of a key concept, is that they wanted to make the experience better for patients, and they knew that they could compete better in the environment that they were in by just doing this new approach where they basically use stitches on the inside to close the space that existed on the inside so that fluid could not accumulate in that space. Now, I started doing it because I learned it from some other people that were doing it, and it was brought over by a surgeon that was working with Grant Stevens, who she had learned it in Chicago from another surgeon. So there was kind of this like lineage of education about this approach. But then in my own practice, I started doing it more and more because and I was really fond of it because we did research, and I looked at the results, and I looked at the outcomes, and I looked at the potential for bad outcomes and good outcomes, and we found that the data was there, really supported using this approach. And nowadays it's something that separates me and differentiates me in the market because I'm honed in on what makes a good experience and what makes a good outcome. Then the main reason I do it actually has nothing to do with the drains. The main reason I do it is because it improves the connection between the body and what's deeper. So you can see the anatomical connections. You can see the line down the middle and the lines down the sides. I want the linea alba to show through. I want people to see a body on the table that looks the way a body should look, not just a Mickey Mouse hand, 3 fingers and a thumb, not just a flat tummy with a little circle in the middle like a board. I was so frustrated with bad looking abdominoplasty results.
I thought so too. I'm like, do you guys think this looks good?
No, it looks horrible. And the truth is that 90% of plastic surgery is bad.
Not even
period. 90% is bad.
I don't know, guys.
But 90% is bad because people accept that. And especially with body surgery, they're like, I'll just put a shirt on. Nobody will see it. It's not a big deal. It's flat. It's tight, and it's like, okay, it's flat, but tummies aren't flat. Tummies have
make it look sexy.
Well, no, make it look normal. Make it look like anatomy.
Don't make it look like surgery.
Don't make it look like surgery. I mean, make it look real so that when you go to a pool, someone says nice tummy. They don't say you had a tummy tuck.
Right.
So, I mean, I think the concept of, and you say the word sexy, which is like
sexy. I just like that word.
That's there's a concept of that, but that's actually not what it is. It's just natural. So it's not just that we make that's
restore anatomy.
Natural is sexy. Right. Like seeing the anatomy is attractive to us because as creatures, we know that if we see a certain amount of anatomic definition, that confers an idea to our deep genetic brain that says, hey, this is a good mate, right? Because they've good anatomy, because they're taking care of themselves,
and they take care of their problems,
functional benefits, and all the things.
Sure,
right?
Plastic surgery is good. More people should do it.
Well, I mean, I think so, but I mean, I'm a plastic surgeon, so I guess I have a vested interest.
But there's people that say like, oh, plastic surgery, what should get done? It's like a negative thing. It's like, well, it's okay because like we're living longer. We're doing this Peter Attia diets and Huberman, and he's this jacked neuroscientist that's brilliant. It's kind of like he seems to be doing it right.
100%.
And like Attia is like a surgeon, and then he's doing a podcast, and he's brilliant, and then is saying a lot of the same stuff. So you start listening to these guys, and they look amazing. And so like listen to the guys who have the credentials, who look good, who are doing the things, and who seem to be not free of conflicts, but they disclose their conflicts at least and like let you know. So I think that's kind of within our field of specialty is to disclose our relationships with regards to like things we're making money off of. Because look, if there's something that I think works, I think we are of the opinion that let's look at things that work. We like to fix things. You're an engineer.
Yeah.
You like to try to fix things and make it work. And I'm not going to get involved with stuff that doesn't. Like maybe it works and it looks magical and I just don't know why, but I like it. That kind of works. But like let's look at solutions. And I think things that look magical eventually, science sheds light on the dark places.
Let me show you a picture.
That at UCLA,
let me show you a picture. Okay.
Okay, let's look.
This is a reset tummy tuck. Okay. Now this is a patient before on the table, and they've got like no shape to their body. Okay. Right. And then afterwards, you see how I've recreated the line down the middle and the lines down the sides.
Yeah.
I mean, this is
it's beautiful.
Yeah, this is a stark representation.
Yeah, send me that picture and then I'll put it up.
This is a stark representation of the anatomy that I can create. And this is on the table.
Yeah, I see exactly what you're talking about.
So imagine if what this patient would look like when the swelling's down and it's healed and and they're in a different position where there's, where you can see the linea alba, linea semilunaris.
Right, the lines.
The shapes here. Exactly. We've improved the anatomic contour between the hip and the core.
It's like when you're a kid and you used to draw like buff guys, where all the muscle lines were. It's kind of like what plastic
better.
It looks better.
And this lady, a lot of people say, oh, her tummy's pretty flat before. Yeah, it is. But look how much skin. Also, look how much skin removed. This little line here is where
it's a Volkswagen versus a Ferrari. I want the Ferrari. It's nice and sexy.
Well, she wants to see her body. She wants to have her body back.
Yeah, but it's because of the curves and the lines that you produce.
But there was also laxity because although it was flat, you see how much skin was removed. The belly button was removed. So that means at least that much skin up to where I marked, that much skin was removed. So there's more tightness. But there's also a repair of the muscles on the inside. So she has her core strength back and a pubic lift. So now she improves urinary incontinence and sexual dysfunction.
The structure below
I lift the below part always. Because that is a key piece. If you miss the pubic lift, you're missing like the most important part of the surgery. That's something that people don't, I just dropped it to you. That's something that people don't often think about. But, and that's a key piece to any surgery. Anytime anyone's offering you a tummy tuck, they should be talking to you about that process. Let me show you another one.
The process of what?
Lifting the pubic area, because that's a key piece that's going to contribute to improvements in function and quality of life.
Yeah.
Wait, let me show you one more.
I'll just show this picture right here, right?
Yeah.
Yeah, that's beautiful. So the one on the bottom versus the one on the top.
Yeah.
So this is the pre and the post, right?
Yep. Above is before, below is after. Now let me show you one other thing, and I have posts about that on my Instagram. But let me show you this patient. This is a patient who's 70 years old. Okay. 70 years old.
Wow.
See this body on the table?
Yeah.
Like if you saw this body, you would think that.
I think she looks good before and after.
She looks great before. I did her breast like a while before that, but look at her after. You see the line down the middle and the lines down the sides, right?
Man, you're making hot 70-year-olds, dude.
Crazy.
You're making hot grandmas out there.
This lady has
hot grandmas.
She has a great body.
They're coming.
She wants to take advantage of it. She's 7 years old. We did a thigh lift as well.
Stay fit and look
She's
good.
fit. She looks good, but now she's able to like.
I see it too, man. In my clinic in LA, maybe in different parts of the country, there's differences in exercise routines, or if there's a lot of hills around, probably, you have to walk up the hills. But you just got to keep doing it every day. You got to get out there. And right now, I'm a little injured and recovering, and it slows you down. And then you just got to get back to it. Just have the mentality that this is something I'm doing and I care about my health because it's important for my collagen and my elastin and my joints, my, stem cells. I got to keep those probably upregulated with exercise. If you stay young and healthy, your body has better ways to heal itself.
There's some other tricks too.
Regenerative potential.
Yeah, there's some other tricks too, though, that I wanted to bring up.
Let's do it.
You talked about, I just sent you some more photos. We'll see if that goes through.
Sure.
But
you can just airdrop them.
Yeah, I did it. Here, wait, let's see. Try it one more time.
Make sure it's
going to
my
the other one. Hold
iPad.
on. Wait. I don't know.
I can send it over.
Michael Stone. You're on everything here.
Do the iPad.
This is what I got. You're not visible. Wait, hold on.
Let me turn this on.
This one? There you go. Got
I
it.
think it's probably because I have my
we got too many things
my
on.
screen recording going.
Okay, so I want to talk about exosomes. Okay.
Sure. Do you want me to show anything about this one? I'm going to record it real quick. So
here, wait. I have a talk I could send you on exosomes.
Did you want to talk about this picture at all?
This is the 70-year-old that I just mentioned.
Yeah, the 70-year-old.
The lines on the tummy, the lines on the side, the change in the shape of her body.
This one too, right?
Yep. Yeah. It's hard to believe that patient is 70. She looks better than many of my patients that are 30 or 40.
Yeah,
also see the back, see the lipos improve the back here, and you can see the curves to her body.
What do you think about genetics?
What do you mean? That's a very open-ended question.
But because somebody would say, she has good genetics. She's 70. She looks like that, and she
does have
surgery.
great genetics.
I can't believe her.
She does have great genetics.
So it is. There's genetic components. And what do you think the genetic components that lead to old ladies looking good without plastic surgery or minimal work? What would you say?
Let's use the word mature patients.
This is your game, Dan. I love old ladies. I hug them and I do surgery on them, and
that's the
they
problem.
Get better.
This is why people seek out plastic surgery, because they do not want to be thought of as an old lady, right?
Of course, I'm just joking.
They want to be known. They want to see their sensuality. They want to get in touch with their beauty. They want people to see that they reach a point in their lives where for so many years they're turning heads, and then all of a sudden it just poof, and they feel like they're in a place of obscurity.
Yeah,
they want to be seen. They want to be seen. They don't want to be irrelevant. Yeah. That's what it is. It's not that they old ladies that want to look pretty. They are,
or that want to look young necessarily.
They are just missing that thing that used to happen in their lives. Many of these women have been beautiful their whole lives, and they're feeling like they just want to get in touch with that again.
Yeah.
So like the biggest compliment I have is I had a patient who I did a facelift on, and she said, I was crazy. I was at a restaurant, and for the first time in years, I got up to leave and I turned heads.
Yeah, good.
People looked,
Yeah,
they were
good.
looking at me because I'm relevant again. I'm like part of the argument. So
I love it, man. Like success stories, like when people are doing well, it's like one thing that I found is like I kind of expected my shoulder patients to be like, yes, I can high five and I can throw a ball, and they're just so happy. And I see that just like sometimes, like when they're just overly ecstatic. It's almost like people expect to get back to normal, right? And so like once they do, they're happy. And so I set the expectations of, hey, if we can get you back to this like functional state, then we're good. If your pain is back to zero,
that's
and
a whole different
if you
game.
can lift and you have strength, and it's all about function and pain, and about looking good is definitely a part of that. It has to do with muscle and about avoiding any kind of like deficits of like deltoid atrophy, or if they're over tensioned and they're really low. People don't like that, and their bras like down. So there's like some overlap with plastic surgery and cosmetics, and especially with like these shadow lines around the shoulder. So open surgery, some people care a lot about that, about their scars. But one thing that I've really looked at is just kind of like understanding like what these people, in terms of my patients, and delving into their lives a bit, because one of the early questions I ask is, what is your level of function and what are you trying to get back to? Because like for me, it's really function. For you, it's really about how, how things feel and look, and, how were things before and how are things going to be in the future. And same thing with me, but people are really about, how am I functioning now? And is there anything that I can do to avoid or potentially elongate my function so it doesn't deteriorate? I always talk about shoulder health, and that's why I wanted to talk to you about like aging and kind of about like what you do to upkeep, or what you recommend for your patients. Because I always talk about, if you come into my office and you don't have any issue that needs surgery or any kind of real significant treatment, but we're figuring things out, I can still at least talk to you about how do you maintain good shoulder health. So I always talk to my patients about stretching over time. Every day you should kind of stretch at least 2 to 3 days a week. You should do rotator cuff exercises to balance your shoulders and avoid tears, and like if you're stretching and you're like, I'm kind of stiff, you also figure things out. You're like, why isn't my arm going back? Then maybe you go in and get seen. So it's kind of like these body checks that we do. You look at yourself in the mirror. How am I doing? My eyes looking, it's like, how do I look? It's kind of like you stretch, you work out, when things are kind of off. And those are the people that are just more in tune, with their body, and they tend to recover more predictably, better, less complications. They listen to you. Like, I think there's these profiles of people that are, people who like kind of like engage with like podcasts, or they're looking for education and they're looking for answers from people who know, who have these credentials that can actually like have these conversations about things that matter, because you can't listen and do everything. It's like all these things online. You're like, should I do this? Should I avoid this? I don't want to avoid cancer. I shouldn't, it's like, what are the answers, Dan Gould? What should we do?
If you're asking me, hey, how do I slow aging? What are the things that I should do to slow the aging process?
Well, I think we already went through a lot of that, but
no, we didn't go through that. No, not at all.
So what is it? So aging process would be like cellular senescence, right? So your telomeres are no longer
face, skin quality, face.
How you look.
Well, you just asked about that. That's what you're talking about.
Yeah. That's from your perspective.
In the mirror,
Look it in the mirror, check it. Like, how do I make this stay nice?
So
longer?
the first thing
Absolutely.
is, so there's 3 things that have been clinically shown to slow the aging process with regards to facial aesthetics. Number 1 is avoid the sun, sunscreen.
Sun damage.
Right. Sun damage is huge.
And sunscreen works, right?
100%.
Okay.
Number 2, oral collagen therapy. We just talked about that a while ago, and I said, hey, there's a lot of argument about this, but the truth is that the science is done. Number 3, topical vitamin A-based treatment. Retinol.
Retinoic acid.
Yeah, because it improves the turnover of skin, it improves skin quality, and it de-ages the skin through activating the pathways and mechanisms of turnover. So those are the 3.
I've used that before. That stuff is, the little cleanup brush on the Photoshop when you can kind of mush it, and that's what it's like when you have pimples. It kind of like makes it go away.
Yeah,
it's amazing.
It gets rid of pimples. That's what its original design is for, but it also is an anti-aging product.
And dark spots too, I think, right?
It improves the hyperpigmentation that can occur by improving
from sun damage.
Not just sun damage, from aging.
From aging.
Yeah, aging causes dysregulation of pigment pathways in the cells that make pigment, and this can kind of clean that up. So topical, and I prescribe that to all my patients.
Amazing.
I prescribe topical Retin-A in conjunction with, in a compounded mixture with hyaluronic acid, niacinamide, vitamin D, vitamin E, resveratrol, turmeric. All these things have been clinically proven through different studies to improve skin health and to reduce aging. And I put them in the concentrations from the studies that they came from through a compounding pharmacy, and we just mail it to them. It's inexpensive, very effective. Because it's a pharmaceutical product.
You send it directly.
Yeah, direct from the pharmacy. It's, it's like $60 for 3 months worth. It works great. It's not a cosmetic product. So those are the things that make the biggest difference, I would say. But then there's also radio frequency microneedling, CO2 lasers, ways to improve the quality of the skin itself as it goes through kind of turnover.
That's cool stuff. Lasers are cool.
Lasers are great. Or oral medications that help to slow the aging process as well. There's some arguments about those, but that's more like senescence in your cells in your body, like mTOR regulators and those kinds of things. But nowadays, the newest product...
Can you do anything about that? About the mTOR regulation pathways?
You can if you take medications to slow them and block
like
insulin.
Or Janumet.
Yeah,
kind of medications.
metformin. I mean, essentially,
metformin.
yeah.
So the anti-aging guys talk about metformin as something that can
they
extend
love
life
it.
For that reason.
They
through
love
the
it.
mTOR pathways,
Listen,
right?
I'm talking about things with great data. Okay, so that's not something with great data.
Right.
But I would just say that's something that people talk about.
So we're talking about anti-aging.
But
that may not be life extension, right?
Correct. The two are different. But I would say that there are other pathways now that we're looking at. One of them is what I keep trying to talk about, which is exosomes.
Yeah, exosomes. Let's get to exosomes.
So exosomes...
How should we even frame that conversation? I know you... So when I hear the word exosomes, it just sounds like science. I don't even know.
Yeah, well, I'm going to tell you what it is. I'm going to tell you what it is.
Let's talk about it.
An exosome is a packet of information in a bilayered membrane, okay, that looks like what the cell's normal membrane looks like.
Yeah, that's even confusing for me, Dan.
So the cells are designed with a certain shape and a certain kind of material, and the exosome is the same, and it's 200 to 300 nanometers. It's very small. It can attach to cells and be absorbed into cells, and then it can take the contents of the exosome and deliver it directly to the cells.
What is the actual structure of the exosome? Is it?
It's a bilayered lipid membrane.
Lipid. Okay, lipid.
Yeah, just like cells.
And it can grab things and move them around, right?
Like it can't grab and move. It is the information that moves from cell to cell.
It is the information.
It is a message in a bottle.
Okay.
It is a message in a bottle. Now think about this in your mind.
And it contains proteins, lipids, and nucleic acids.
And all kinds of other things.
Cool.
But phosphorylated proteins.
They sound cool. They have
phosphorylated active proteins.
Wow.
So and it can have markers on the outside that target it for absorption. But think about the message in a bottle. You think right now in your mind, picture a bottle with a message in it floating in the ocean.
Are these recombinant, or are these are they made? Or?
They're not recombinant. They're made by cells. You can also genetically engineer.
You harvest them.
But wait, think about. Let me finish my.
I'm sorry.
Keep interrupting me. Okay, you've got a message in a bottle. Floating in the ocean. The message inside the bottle is just as important as the bottle itself.
Okay.
Because if there was no bottle, the message would be on the bottom of the ocean. Okay? For it to get from one place to another, to get from one island to the next, it has to be in the bottle with the cork in it. So it doesn't fall to the bottom of the ocean, right?
Got it, yeah.
So the exosome is the bottle. What's inside of it is the message. You can create the message however you want it.
Fine.
Now, the most common exosomes that are secreted within our bodies are regulators of cells that one cell creates to send to another cell. So you've got endosomes, exosomes, you've got paracrine signaling or autocrine signaling that's mediated where the cell regulates itself or other cells by secreting something to go to the other cell and tell it to do something. That's what exosomes are.
Okay.
Now, the best example of that in aesthetics...
Can I stop you just for 1 second? So just to go back to the bottle example. So the message is in the bottle, and then the body has ways through the endocrine and paracrine system. Kind of paracrine is kind of where the cells secrete things nearby, and endocrine is from far away and it's sending signals.
Yep.
So then the body has ways.
And autocrine. The cells can regulate themselves.
And then within the cell itself, right? Mm-hmm. And so then all of those things are active, and then once there's this exosome from somewhere, either endogenous within the body makes them, right, to have some kind of way
exogenous coming from outside,
or exogenous communicating within the body. Those can be maybe upregulated, downregulated, and controlled by the body, right? So then there could be maybe a lot of messages, or there could be just a few messages, but then you could have this kind of shift in information or signaling throughout the body. Is that right?
100%.
Thank you. I understand.
People used to think exosomes, they used to think it was garbage. They thought it was
sounds cool.
dust. Yeah. They thought exosomes were dust, like leftover bits of cells that just were part of
scraps and remnants.
Fragmentation of cells, right?
Yes.
And then there was a really cool scientist, his name was also Gould, Stephen Jay Gould, not related, who figured out that exosomes were a critical piece of autoimmune disorders and cancer and cardiac disease. Now there are one company that was using exosomes in order to improve cardiac disease, and they found that the exosomes actually had an aesthetic improvement. That people that were handling the exosomes that had sensitivities to latex gloves had improvements in the sensitivities by using these types of exosomes. Now, first question with exosomes is always like, okay, well, where should we get them from? Like, what should be the source? And I think that the best source, one of the best sources, is platelets, because platelets are an important cofactor in Platelets are an important cofactor in wound healing, and platelets have been shown to be valuable in healing. We do PRP, PRF,
platelet rich plasma.
Right now, why do we need PRP? What's in PRP that's so valuable?
It's useful for healing, right?
Platelet-derived growth factors, right?
PDGF,
and VEGF and FGF.
Right.
But there's also other factors. But the bottom line is platelets go in a wound. Platelets are part of our blood.
Okay.
They go in a wound where there's a cut.
Okay.
The platelet sticks to the place in the cut, and then releases the alpha granules and the delta granules. And those granules that degranulate, they release PDGF and FGF. But how do they release it? In an exosome. Okay. So,
no way.
Yes.
This is full circle, Dan.
Come from platelets.
So it releases exosomes.
Calcium triggers the release of the exosome, which contains a growth factor.
Okay.
So there's a company now called Plated. Ryan Pharmaceuticals, Plated. And what they do is they stimulate the release of the exosomes from the platelets, and then they package them and put them into a cream.
They just kind of cut out the middleman of all this injury.
Exactly.
Like, hey,
and instead of injury, you go straight to growth.
Yeah.
Which is amazing. You don't need a laser. You don't need a microneedling to trigger the growth factors, to trigger the platelets. You can just put this on your skin, and it's like having a vampire facial every day, 2 times a day. It's amazing.
How do you get these exosomes?
They go to a blood bank. They take platelets that are pooled platelets that are leftovers that nobody uses, because we use very little platelets in medical practice.
Yeah.
And then they degranulate the platelets, and then they take the exosomes and they pool them, and they put them through a process of proprietary cleaning them, making sure there's obviously it's a blood bank, it's pretty safe.
Yeah.
And then they put them into a product that's shelf stable for up to 2 years.
And these are medical products that would be something that you use off the shelf?
Yeah, you would get it from a physician's office. But
you use as
it's actually a cream that I prescribe to my patients.
Wow. So it is. It's in prescribed creams. It's not over the
topical
counter in any way, though.
You can actually get it over the counter. You can order it online.
What is it? What do you know any?
Plated.
Companies? Oh, Plated.
That's the name of the. Yeah, that's the product.
Wow.
It's called Intense Serum. They have different serums. Some are only medical, but you can get these products available online.
Oh, okay. So that would be for like skincare.
Yeah, for skincare, but also for improving the quality of your skin and anti-aging. And they did studies that showed that it decreases P16, so it actually stops senescence. It down-regulates senescence and actually makes the skin act like it's young again.
I wonder if there's something there. If anybody's doing exosomes for this life extension stuff, flood your body full of the good stuff. And
I mean, exosomes seem like the cure because the stem cells are great because of what they produce.
Yeah,
the stem cells are the factory.
Right.
We like them because of what they produce.
But the exosome seems like they get things.
The exosome's the signal.
And
that's what they're producing.
So you probably need stem cells and exosomes.
If you have stem cells, you got the factory. But if you got signal and you can figure out exactly what signal you want, great. The problem is most exosome products nowadays, they have ones from MSCs as well. They're like a bag of mixed nuts. And it's like, dude, I really like macadamia nuts.
Yeah.
I don't like Brazil nuts.
Right.
I really want cashews. Give me all the cashews. I don't want the freaking, peanuts. So that's the problem. So right now there's this huge push to purify and really qualify what's in them. And a lot of it is nonsense. So I'm actually doing a study with UCLA, Proteomics Core, where we're looking to create a mass spectral fingerprint for exosomes, for quality exosomes, so that people that are selling these products can actually send it in and validate that it's actually legitimate exosomes that are in there. Because a lot of companies that are there selling these products are just pirates. They're selling nonsense, garbage.
Hey guys, I got some exosomes for you.
Where'd you get them from?
Sale.
My trunk.
My
what was the source?
I got some snake skin
we
exosomes.
Get them from stem cells. What kind of stem cells? I don't really know. Where? What lab? I don't really know.
Then they're out.
Third party, like whatever. Oh, is it validated? Yeah, we have a third party that checks the purity. Can I see the purity? Goodbye.
But that's why what you recommend is so important, and what I recommend is important because, we care and we look at follow-up. People come back and say, hey, I got this is not working, or hey, this works great, and you see it.
and safety, like we don't want to hurt anybody, right?
Not.
So I would just say like, hey, you got to make sure that it's a safe product. Like I personally like platelet derived exosomes because I know a lot about wound healing.
Sure.
Stem cell derived exosomes, I'm kind of a little skeptical of.
Gotcha.
Because stem cells play a role in cancer, right? And there's issues that I don't think we fully understand. But platelets, we really understand wound healing.
Yeah.
And I did a whole PhD on PDGF and FGF and VEGF, right? So I know a lot about those growth factors. And I feel like in my practice, that's the thing I'm most comfortable with, is the thing that I have knowledge about.
Sure.
I don't know a lot about mesenchymal stem cell exosomes. So I feel comfortable with that material.
How much have you changed in your practice since you started?
Oh, a lot. What kind of a question is that?
What percentage?
10,000, and you should be doing 100% change every year. I mean, you should be changing and evolving. Now the techniques have changed, and every time I do a surgery, it's different.
Right.
Every time I operate, it's better. I haven't looked back on a single one of my surgeries and said I'm 100% satisfied.
Sure.
There's always something I see that I could have done better, 100%.
Right.
So I'm just constantly trying to get better. In my practice, I iterate that process into my routine. So on Sundays, I sit down and I do case review. I look at the patients that were 3 months post-op from the week before and afters, and I send them an email with a before and after. Say, you look so good. Do you mind writing me a nice review? It's a good opportunity to connect with them.
Yeah.
Talk about our future plans. I need to revise this. This looks okay. You're coming for a CO2 laser to make scars look better. Let's make sure you're taking the topical medications to improve your skincare. And then I look at the patients that are coming up in the next week, and I look at the before and after photos and the plan, and I ensure that the plan matches their needs.
Right.
And if there's some kind of disconnect, that's my one last check stop to be able to be like, you know what, this patient really needs a lower blepharoplasty too, and we didn't talk to them about that. Or we need to optimize skin. Or you know what, we looked at medical clearance, and I know that we talked about this, but we need to have a good discussion about your factor V Leiden
You're
disease.
looking at optimizing.
It's looking at iterate.
You're always trying to make things better.
I am
Every
Sigma
little
6,
detail.
baby. I am Sigma 6. I'm not happy until we are 6 degrees
I like it.
apart from everyone else.
Yeah.
And I iterate that into the aftercare process too,
Yeah.
So
Standard deviations is what you're talking about.
yeah, Sigma 6 means 6 standard deviations from the norm. And that means
Is that what you consider yourself when you go out to the bars? You're a Sigma 6. That's going to be
I don't
my
go
band.
out to the
I'm
bars.
I'm going to name our next band Sigma 6.
I wish I had time to do
We're
that.
6 standard deviations above the rest. We're rocking. Dude, I've been playing rock and roll music again.
That's good.
I got my boys here. We're
Getting in
doing,
tune.
we got the,
See, you like
we
the
got
joke?
the setup
Getting in
at the
tune.
LA Shoulder Studios.
Getting in tune. That was my dad joke. It was
Getting in tune?
getting in tune with each other.
We got to tune
With
first.
yourself, yeah.
We got to tune it up, boys. Yeah, man. I've been doing a lot of personal reflection, because, like, man, like you just like the way I look at you is you're a scientist who came in. You're this nice guy who's exceptional, and you just want to help people, kind of like become better, and you want to help your patients. And I just see you as this kind of like all-star. And then you went out in practice and, really did amazing things. And then, now you're here and you're still the same guy. And I think it's so cool, to have you back over here kind of full circle.
Not much changes.
Not much change, right?
Yeah, if you change in response to your stress or your environment, that's not a good thing.
Sure.
So I think resilience is what makes us who we are. Now, when you say going out and doing, I've taken the same concept that I took from residency to my practice. And the thing that makes me different.
And you may say the same thing about me.
100%.
Right?
I agree with that. 100%. Now, the thing that makes me different in the world of cosmetic surgeons is that I am still that. I'm pretty transparent.
You uphold these
I
core
care a
values,
lot about the patient.
Right? Exactly.
Someone just wrote an
You always
article
have.
about me about aftercare because no one else is doing it, and it's like that's fucking stupid.
That's
like,
kind of what I was asking.
How is it
about,
not possible that these
what's the whole package that you get, right? Because that's what you care about is the whole package.
and care?
Come
Like
from
I
start to
treat
finish.
patients the way I
What
want my
matters?
sister to be treated, like or my
Some
mom.
things
like,
don't matter that much. Some things matter a lot.
Some things matter a lot,
A whole lot.
And if it matters even a little bit and not a lot, I'm still gonna do it.
Pay attention to it.
I'm still going to fucking do
Sure.
it because why wouldn't I? This is
Right.
cosmetic surgery.
Absolutely.
We're literally cutting you open and risking your life to make you look better.
Yeah,
That's
it's
fucking
making go
crazy.
from here and just moving the needle over.
That's
a little
crazy.
bit, which
so
is
we
even
cannot.
harder.
So we cannot fuck it up. We
You
have to
can't.
be sure that we
There's
don't risk
no room.
safety and we don't make you look worse.
It's like eye surgery, similar. It's just
You
like-
have to just be thoughtful about the fact that you're risking a lot. So if you're not doing everything to make it better,
Right.
you're missing something.
Right.
And I actually, this is so funny. There's this article about me and aftercare and what I do. And the person who wrote it quoted me as saying that you could probably prevent 90% of the types of issues that occur in the first 24 hours if you go and see the patients the night of surgery,
Yeah.
right? And then this person who's like
I don't want to see him.
a fellow. So a fellow wrote a
Somebody can
response
call
to
him.
her.
Just
Somebody
call
who's
him.
still in training, not
Yeah.
yet board certified, said, I disagree with this statement. There's no data to support this. And then he went on and on and on. And then he said, more importantly, it's dangerous because if a patient has a bad outcome, they'll sue their doctor and say, you didn't see me the night over the next morning. And my response is, yeah. if there was a complication you could have fixed and you didn't because you didn't see your patient, then yeah, you should be liable, because that's the whole point. This is cosmetic surgery. This is not cancer life-saving surgery. Yeah. This is not reconstructive surgery of the shoulder.
It's avoiding
This is cosmetic surgery. Yeah. So you should be held responsible if you're not doing those things.
Higher potential liability
and higher bar of care.
Right.
These guys
that those exceptional
these
outcomes,
men and women that are cosmetic surgeons that are out there just cutting and running, cut and run, like they deserve to be smacked, because dude, this is someone's mom. This is someone's sister. This is somebody who's risking a lot. And if you're not fully devoted to that patient, it's different than someone who is dying from cancer.
We're not promoting violence.
I'm not promoting violence. I'm saying that they deserve to be held accountable for the quality of care for their patients. Well,
because if they've been doing, have you seen these Instagram where they put these crazy ortho, weird, crazy pins that are all, wonky, out of place, and then they post their X-rays and show how messed up they are.
I love it.
And it's like,
and you're like,
guys, this is not funny. It's somebody's leg, but also good. Show it.
Yeah.
Like, because otherwise the patient thinks it's fine. And they're like, why is my leg hurting? Oh, you just need more surgery or whatever. Or they're gone because they're just covering the hospital, and it's not acceptable. Because there's people on the other end of that.
I think we need more transparency, but I think orthopedics is like the last bastion, because no one, the X-ray don't lie, right? The X-ray does not lie. When you put together a good fixation, everyone knows. You can see the intermediary, you can see the rod, you can see the pin, you know where it is. You turn that, we know the angles that are required to see the correct views and to know that it's in the right spot. Honestly, a video ranging it is really when you really see the difference, right? Like you're doing fluoro, now you know for sure.
You have your checks and your ways to know.
But that's something that we talked about earlier. You said patients, they want return to function. But what I would say is they don't understand the difference between like a beautiful, perfect fracture fixation and like 3 pins and rods that were just jammed in there, but they recovered anyways, right?
But they know what their boobs should look like, and they know what good boobs look like. And that's why I wanted to get to you about crowdsourcing. I think that idea of like, because like I keep wanting to talk to you about that, because it's so interesting, because we all kind of know my shoulder goes up and down and out. It should be strong and not weak, and it shouldn't hurt. And that's kind of all agreed on. But what is a good looking cosmetic outcome for breast augmentation, and how is that kind of established? And when I was in training, this guy came in and he talked about, I can't remember his name, but he was a plastic surgeon, and he was showing us noses, and then he showed all this research on noses and about the contour and about the ratios and about like how much offset there was. And then it was kind of like, well, most of these look pretty good to me, or some of them look kind of bad, and it's all agreed on, like the ones that are on the bell curve, like on the extremes. And then otherwise, most things are kind of in the middle where they look okay. And then like the bell curve on the other end when they look exceptionally good, right? Yep. So then he was kind of like looking at like, okay, what do the exceptionally good ones look like? So how is that derived? What are the exactual ratios? And, he was able to kind of quantify these things. And then he was basically saying there's people that look like Chris Hemsworth that everybody agrees have these certain ratios of structural soundness that makes a good looking nose, and then there's other people, like other examples of females who have a little upslant to their nose, and the kind of like different types of ratios within certain limitations that he was quantifying. And it was something that he had spoken about in terms of kind of like a review of the literature. So what was interesting to me is like the crowdsourcing idea of some of the research that you've done about looking at what basically surveys of what people think looks cosmetically appealing. Is that right?
Yeah. I mean, I can tell you what looks good because we just asked 50,000 people, right?
Yeah. So 50,000.
Yeah. I mean, crowdsourcing has to be volume, has to be high volume. So, I mean, what we've done is we've taken, studies where we take thousands of people. We ask them, hey, what do you think looks good and why? And then we use that to guide the process.
Was that a survey that you sent out?
I've done over 40 peer-reviewed publications on crowdsourcing, and I'm part of a company called Pictoria or Love My Delta that all we do is crowdsourcing. So we work in the cosmetic space to do clinical trials. So you say your product makes people look better, let's find out, right?
What's it called? What's the company called?
Love My Delta, LMD, or now it's called Pictoria. So we've changed the name because it's more conveys the idea that a picture can convey a million words. So we also have products. We have an app called Jackie, which is a product for the med spa space that helps injectors to identify aesthetic outcomes in their own patients and improve the care. You can go to the website. It's Love My Delta. Pull that up. But so
it's
Love My Delta. You'll find it there. LMD.
.com.
Yeah, just search.
search?
I don't know if it's .com, but
This
yeah,
one?
that's it. Love My Delta is now
The
pictorial.
girl with the pink hair?
Yeah, well, the example is, hey, how do you know it looks aesthetically good?
Oh, okay.
So,
right here. I see.
Yeah, go to the Pictoria site. Yeah, go there.
Okay.
So Love My Delta does a few things, but it's basically visual-based research where we take platforms and we take pictures and we say, hey, what looks good and what doesn't look good.
Do you use AI for that?
We do use some AI in training the back end, but we collect data that faces 3 or 4 different ways. So we
This
use
is right here, humanized AI image evaluation.
Right.
So you use it to evaluate.
well, you have to use humans. You crowdsourcing.
They need the data.
because the
Human
AI
data.
is
AI
the
wants
AI
human
is
data.
fine, but it's not good. And humans can tell you what looks.
It's
good.
dependent on the input that we give it.
Right.
So if you guys aren't doing pictures of people and we're not putting it and say what looks
And
good
putting
and
it
what
in front
looks
of
bad,
other people to
exactly.
train it.
You need the
Yeah.
opinion of what other people think.
Well, that's why we use crowdsourcing to train AI.
And then the AI can figure it out.
Yeah, but it has to have like 50,000 input
It
points,
needs
which
the
is
input.
why we do what we do. That's why this company is so freaking exciting. And I mean, look, they came to me because I'm the world expert on crowdsourcing for aesthetics. Truly. No one's written more articles than I have.
Yeah.
And now with them, I've written more articles where we're using the technology and the data science to improve the quality of outcomes with regards to crowdsourcing. But we use it to look at things like, what's the ideal breast? What's the ideal abdomen? What's the ideal thigh? That kind of question.
That's your Instagram right there, right?
Yeah, that's me.
Dr.
Gould Plastic Surgery. That's me. And my TikTok is the same, Dr. Gould Plastic Surgery, but it's
You were doing this a long time ago, and I think I've been watching your Instagram for a long time, and
Yeah.
you've been doing it very similarly for years.
Yep.
And I think it's nice because they're getting it directly from you. It's one-on-one. It's like, hey, this is what I think, and there's nobody kind of in the way of that.
yeah, social media marketing. I mean, we wrote the first article on social media.
Oh,
and
you're friends with
plastic surgery.
Pumanator.
Yeah.
Pumanator.
We did the first article on social media and plastic surgery going back to 2013, where we said, hey, what is social media? How does it fit in this situation and in the current kind of landscape, and how do we make it good and ethical? Because that's an important part of social media, is making an ethical situation for patients.
So
right?
I want to get to you. I want to ask you about social media. I want to take a quick break because I got a camera issue, and we'll get right back to social media. Okay,
Perfect.
let's take a quick break.
Mm-hmm.
And we're back on the LA Shoulder Podcast, talking with Daniel Gould, MD, PhD. We were getting to the discussion of social media. So, what do you think about social media? Obviously, I think you have 35,000 followers and
On Instagram.
plus
200
on Instagram.
on TikTok.
200,000 on,
Yeah.
on TikTok. That seems to be some kind of logarithmic, like to the order of 10, I think, on TikTok, maybe 100x, whatever. it
TikTok's
is.
more viral. It's different
more viral,
content.
and it goes faster. I've been doing a lot more on YouTube. That's most
YouTube is the best.
yeah.
YouTube is the best because it's an open platform and you're incentivized to link out. So YouTube is on the Google search.
Yeah.
And when people pull up a video on something, if it's on YouTube, they're going to link out, and it will be the first thing on SEO, and it will power their entire social media platform.
I've noticed the videos are really relevant too. Even stuff I've been using YouTube a lot more lately, just because it's like
Best educational content.
and whatever I want to look for, kind of is there.
Yep. So YouTube is it. I actually am
Short videos, long videos, like either way.
I'm actually verified on YouTube, so I'm trying to build up that platform.
Sure.
But,
What's your YouTube? I'm gonna let me pull it up
Dr.
right now.
Gould Plastic Surgery, same thing. But
I don't
but
know.
I would say, yeah, Instagram is more like visual, so before and afters content, video content. But it's very structured, and they're very careful about like what they allow you to show on Instagram. So there's a lot of shadow ban associated with.
This one's mine. You're subscribed to me, right?
I think so.
Yeah, make sure you do. I'm gonna find yours. What is it?
Gould Plastic Surgery.
Gould Plastic.
But TikTok
What-
is more like educational short form.
So what kind of stuff do you put on here? What kind of videos do you have?
This
on
is
here?
mostly just like information about the practice, information about what to expect from surgery.
1.7 thousand subscribers. That's impressive.
I don't even know. I haven't even put videos on there in a long
Do you
time.
make any money off of YouTube?
but-
Do you make any money off of social media?
yeah.
Through
Oh, yeah.
what's the best?
TikTok.
Yeah.
Yeah.
So-
Probably a couple $100 a month off of TikTok. It's pretty good. Pays
Yeah.
for the like filming and stuff like that. But the future is all YouTube. I'm building out a whole new channel. So the concept is I actually want to put together a TV show for YouTube that's going to be called The Reset.
Very cool.
Where we look at reset lift and reset tuck, and we profile patients going through the process. The Gould Plastic Surgery TikTok YouTube is designed to.
It's got 51,000 views.
Yeah, people want to know about me. They want to know about the practice. This tells you who I am and what I do. So
Let's meet Dr. Gould, board certified plastic surgeon.
And
Yeah.
I want to take a moment to talk to
Look,
you
how's-
about who I am.
This makes
and
you look
why I'm different
professional.
from other plastic
well, I am
surgeons.
professional, Mike.
First
Yeah.
off, a lot
But it
of
makes you
patients
look that
ask
way.
me,
Yeah.
Because when they
"What's
see
your
you at
training?
first, they
Where
don't
do
know
you come
you.
from?
But this makes you
And
look
what is it that
professional because you
motivates
are
in
professional.
plastic
Yeah,
surgery?
these
How are you
videos
different from other surgeons?
really help people to understand
Well,
the
my answer is
process
pretty straightforward.
and what's going to happen
So
in
I
surgery
bring that
and kind of how to prepare for it. So I think
You explain
other
kind of what you
surgeons.
do in the
I'd say there
process
are
of
many ways that
surgery.
I'm
And
well, yeah, there's tons of videos with different concepts. Like,
this is great.
yeah, there's a lot of information here. But
How did you get all this video content? Did
the
you have
stuff
a?
with the white background with those
Yeah,
things?
this one?
That
The
was
squares?
1 day, 5 hours. Every single one of these videos.
You
is
just went boom.
no cut. I don't cut.
Well, you're great at talking. Put you up in front of a microphone.
You can
and-
put me on camera. You don't have to
Look
cut.
what we're doing.
You don't have to cut.
We don't have to
improve the
cut.
quality of outcomes.
But,
I knew you'd be
For instance, in
great.
body
Yeah, see, this is the
composition,
Dan Gould I knew
I
way back when.
utilize-
Yeah, 100%. Because I know exactly the message that the patient needs. That's what I'm trying to convey. That's what I'm trying to educate with. But then there's other videos on here that are videos that came from our other, they're shorts that come from our other content.
Sure, but it's a repository of all your video
it's good.
data.
It's good, but like there's some videos that have very few and some that have very many, and it's like, why is there a difference between them?
Have you had anything go viral?
Oh yeah, on Instagram and
Yeah.
TikTok a lot. Yeah, 3 million, 4 million views.
Oh wow,
Very common.
that's cool.
Yeah. I mean, they're just great results. That's the thing, is what you'll see on
Yeah.
my Instagram and my social media.
Sure.
You'll never see me running over a breast implant with my car. You'll never see me dancing. What you will see is amazing results.
Right.
And that's what I
Just
want
keep
to put
that
out there.
going.
Well, because patients,
Show what you're doing.
You can get followers by doing crazy stuff,
Right.
but that doesn't mean more surgery. But if you show great surgical results and great before and afters, that's going to get you more surgery. And I don't honestly care about how many followers I have.
Sure.
I just want to be able to operate and do what I love. And doing that is in finding patients on social media that want what I can do. So the main reason I have social media is just to attract more surgical patients.
That kind
That's
of
it.
makes the ethics of social media and what you do and kind of what I do pretty straightforward.
Simple.
Pretty simple.
Yeah, it's not dirty. You don't have to worry about you don't have to worry about what you're doing if the motive is correct. If the
Yeah.
motive is correct, I want to improve patient education. I want to improve outcomes, and I want patients to find me that want what I can do.
Yeah, let me teach them some things
Let
that
me
are
teach you about
going to
it.
make your life better.
100%.
So the other thing that I wanted to bring up was we kind of talked about it a little earlier. Maybe we can kind of sum up the biochemistry talk with the talk on BPC 157. So that's a peptide, right?
Yeah, body protective compound 157, and it
Can
comes.
you go over that?
Yeah, it's it's an enzyme that comes from the stomach that we don't really know a lot about, but basically it is a pro-healing peptide that has not been fully evaluated or proven by the FDA at this point. But everyone
What's a
seems-
peptide?
It's a small, basically it's a chain
It's
of
2 amino acids, right?
Yeah, chain of amino acids that stimulates some other activity in the body. Now, peptides are something that I've been interested since my PhD because we actually had proteins like VEGF and PDGF, but if you would put it on the shelf or you'd take it out of a cell and leave it on the counter, it would only be able to live for like 24 hours in its active state because of the folding of the protein.
Right.
But then if we take a small sequence of peptide from that protein, that is the sequence that's the epitope that activates the epitope binding region. So it's the part of the protein that's functional. If you just take that functional bit,
Kind of the active part of it.
it would be effective as effective as the protein. So for instance, for VEGF, we had a compound called PQ, and we would pegylate it, and meaning add it to a backbone.
Pegging them?
We would pegylate it. We would add it to the backbone that adds it to the actual matrix, which is the tissue engineered scaffold, and it would be just as effective as putting VEGF in. And we had one for PDGF as well and FGF. So we knew back in 2006 that we could take a small peptide and it would be just as active as the full protein, and it would last longer and it wouldn't degrade, and the signal was high throughput. So nowadays you have these peptides like that, and you have Cimarillin and other ones that are designed to mimic some of the aspects of growth hormone or other insulin-like peptides or insulin-like binding regions, and they stimulate health. They stimulate healing by stimulating the growth part or the anabolic phase of that process without having to have the completed peptide or the completed protein in its fully active form.
Upregulation.
Upregulation.
So they kind of stimulate activating things.
They
terms of,
basically,
like-
it's like the signal in high fidelity with very little noise. It's basically like saying,
It's puro.
it's the purest version, the
Yeah.
purest form of it without any of the nonsense. It's like taking just pure caffeine instead of a cup of coffee.
It's just like a
Yeah,
lock and
we
key.
can just lock it in there and it doesn't degrade, and it's very stable, form stable, and shape stable. So those peptides that you hear about now, like for instance, GLP-1s, right? So these
glucagon-like peptide.
Right. So these are peptides that stay around a lot longer than glucagon, than the GLP does in our bodies, or the active version of that in our bodies. And they're more effective because there's no background noise, and they circulate and last longer. So these medications are far more effective in that reason. So
then how are these peptides used in a clinical sense? Because I haven't used them personally. How do you use peptides?
So I would just say this: peptides can be used to improve healing, and so
Can be.
yes, and so in
Maybe.
patients. And in patients that are losing weight that need to preserve muscle mass, they can be used to help improve muscle mass retention. That's how most weight loss practices are using semaglutide.
How are they taken? Like, how are they ingested?
It's injectable, just like the GLP-1 inhibitors,
from a clinician,
just like
or
semaglutide.
people are doing it on their own.
Many people are doing it on their own without clinicians. There are
Not under
nutritionists
physician
prescribing it.
guidance.
You can buy it online, and it's totally unregulated, which is not great.
I see. That's what I thought.
But if you're getting it from a physician's office, then, and I have heard of physicians that are doing weight loss that are using it in conjunction with weight loss medications.
Weight loss. That's peptides for weight loss.
They're using, what we just talked about.
Specific ones.
Semaglutide, tirzepatide, Mounjaro, right? These, Ozempic, Mounjaro.
Are those peptides?
Yeah.
Ah.
Yes.
Those medications are peptides.
That's why it's super easy to make them and why they're compounded so easily. Yeah.
So Mounjaro. What are the other common ones?
Semaglutide, Ozempic,
that's the one.
Mounjaro, tirzepatide.
Those are peptides.
Yeah, and the way that they're made is a little different in compounding.
Recombinant peptides. It means they're made in a lab.
They're made in a lab, but you can do peptide synthesis at home. There are devices you can buy that'll just
Maybe
do it
you
for
can.
Yeah, I mean you can buy peptide synthesizers online.
No way.
Yeah, you can. But I would just say that they're not
Biochemistry in your garage, brought to you by peptides.
Yeah, I mean it's really phenomenal.
Happens.
Well, I mean, we like amino acids, right? And we can get amino acids in bulk.
I've been taking a lot of essential amino acids.
An amino acid is the basic building block of a peptide and a protein.
Ah.
So you just take the amino
maybe
acids.
You're stimulating those pathways.
Yeah, you just take an amino acid and it's fully bland form. You're putting it into this machine that just boop, 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 and triggers synthesis between them based off of the linking that you want to do.
Right.
It's like plug and play. In the future, we'll have our own peptide synthesizing machines in all of our houses, and you'll say, I want collagen, and it'll do, and then here's collagen in a bottle.
Are there different differences in the peptides in terms of their amino acid profile, or is it other differences in their side chains, like how they work? Because it's only a few, right? 2 or 3.
There's not that many differences. Yeah, you can maybe add in a hydroxyl group here and there, or aminate
different
1 or 2
biochemical ways you can alter them.
Yeah, not relevant. What's relevant is peptides in a certain sequence trigger the same activity as a giant protein without having to float around your body.
But my point is, certain peptides can be useful, and other peptides may not have the same effect. That's what I'm saying.
Right, and some may be damaging.
And how many peptides would you say? Could you give a ballpark of clinical uses? Like, is there like 100 of them? Or is there only
millions?
There's millions.
Millions of useful peptides out there. Because
that's amazing.
Think about it. Each protein has like maybe 10 or 11 binding regions that are effective in the process of.
And it's just the exact ones for those domains in the in whatever enzyme or whatever it's activating.
Depends on the shape of the protein and its function.
Yeah. And maybe there's some, I'm sure there's some that just haven't even been discovered. Some useful
How many tools exist at Home Depot?
Well, you could probably make even new ones or combinations of tools.
If I stick a wrench on top of a screwdriver, it's a new tool.
Right.
That's the analogy. So
does different things.
For proteins in your body. Now think of each of the little pieces of the tool that you could take apart and put back together. That's the peptide, right? That's like the little drill bit on the tip of your screwdriver,
Yeah. Do you think AI will have a way that can kind of give us answers for those kinds of things? Or
they have it. They have whole databases.
More relevant questions.
They have whole databases where you can actually search for peptides that may be useful in certain situations.
Oh, yeah?
Based off of the peptide binding region or the epitope binding region that you want to match. So you can engineer proteins in order to work as cures for certain types of diseases.
Let's look that one up. I think that's a useful topic to look up.
They also have
engineering
proteins,
peptides, right? Using AI technology.
They've already had databases for that for many years. I mean, going back to 2013, there was a lot of work going on that. But I would say nowadays, the advent of much more powerful computing for AI, thanks to NVIDIA and some of the other chip producers that are out there.
It's kind of dependent on how powerful these chips are. It's a big part of it.
There are other companies besides NVIDIA that are producing very high-end chips, but I would say,
there's a big race going on in the chip company, in the chip world, to try. But they have some technology that other companies, as far as I know, can't have been able to replicate or duplicate in a certain way.
There's one
that
other
they can compete
company
with.
that's getting close.
But NVIDIA is one that I've been keeping an eye on for sure. So AI-driven peptide design, generative models, engineering peptides to develop novel therapies, not only possible, but actively transforming drug discovery processes. So people are really already doing this industry.
That's how we find drugs. That's how we find ones that work.
Wow. So peptides is a huge field.
Yeah, it's like the biggest field in proteomics. And my undergrad, I worked in a lab that was a lab focused on superoxide dismutase, but we did proteomics. So we looked at peptides, peptide sequencing, and inorganic chemistry to figure out how to reduce oxidative stress in the body, anti-aging, neurodegenerative diseases, and other protein-related science. So
I'm going to ask this one. Are there relevant applications for peptides in orthopedic surgery? I'm going to compare what you say to what ChatGPT says.
Yeah, 100%.
Because we have a human ChatGPT here with Dan Gould.
I mean, I think that there are many uses for peptides in orthopedic surgery.
So, but what can I use as a shoulder? I've never even used these. What could I use? Can I use any of these? Because you're brilliant. What can I use as a shoulder surgeon? Can I use this at all? Would this help what I do? Do you
probably.
think? Yeah. In what way? Do you think I could inject people?
Well, would you give patients growth hormone?
I've been thinking about that, like testosterone, not necessarily, but maybe getting a full endocrine evaluation. Like, for example, elevated testosterone levels increase your risk of infection. Right. And guys 10 to 1 have
DVT and PE.
Sure, complications. And so if people are on testosterone supplementation before elective surgery, absolutely they should stop. People don't, we don't even discuss that in orthopedic surgery. And so this is coming out now. And so you're much more in tune with, endocrine evaluation and, the role of hormones and how that affects healing.
I stop them all 2 weeks before and 2 weeks after.
Sure. Okay. So then people who are supplement, I've been doing that too. And there's data to support that 1 month. Yeah. I stop them 1 month before elective surgery now. But I ask people about it. And they can resume afterwards, I think, as well.
But would you put them on growth hormone?
So what your question about that is, I don't know how to manage it. And so I would say yes, but I don't know how to manage it.
What if you had a peptide that mimics growth hormone?
Yes.
So you don't have to manage, you don't have to worry about, bioavailability and all that stuff.
Right. Let's put the lock and key in, and let's say, it's kind of like the XR stuff. I mean, I think there's a role for it. After a year or two, maybe there's no role.
Right. But maybe it's effective the first week or two.
Maybe there's a critical role the first
That's why it's
weeks.
better than stem cells, because you put them in there for life.
Yes.
You don't put a stem cell and you just put the exosome or the peptide.
That's how it's baked into the pie.
Yeah, but if you just put the ingredients in and they're only enough for one pie, you're golden. You don't have to worry about a lifetime of where these stem
Use
cells
good ingredients from the start, and you always have a delicious pie.
Better ingredients, better pizza.
Better pizza.
Everybody knows that.
Better pizza, Papa John's.
I hope they come for us on that one. Don't say that.
Not sponsored by Papa
Better
John's.
Ingredients, yeah.
Better pie.
No, because the concept
good
is
East Coast accents.
The concept is that if you take the peptide, you take the protein, the active portion of it, you use it appropriately, you can take advantage of the action, and it's not permanent, and it's not going to create a problem in your patient. I think it's the safest way to do it. I like exosomes as a delivery because it's the best way to get it into the cell that you're targeting. But I think that, there's many uses for peptides in orthopedic surgery. I don't know if the FDA would, is going to clear all these opportunities, and I don't think that it's up to the FDA to really investigate them. I think it's up to us as surgeons to say, can we do studies and trials in a safe way to improve patient outcomes without risking anything? But I think in the next 5-10 years, there's going to be what it will be is you'll come in for surgery. We'll run a panel. We'll identify vitamin deficiencies and potential weaknesses in your healing profile. We'll even look at your telomere length. And then we'll come up with a supplemental regimen for you that matches those issues and that improves your outcomes. And then 4 weeks after, we'll transition you to a lifetime supplement that's designed to prevent it from happening in the future.
Can you measure telomeres? Can you do that? Do you know?
There's studies. There's different technology. There's one where you spit into a cup and another one where they take blood, but they can check your telomere length.
And they can give you some kind of cutoff and saying like...
Yeah, they just say yours are short.
You get pretty short there, buddy.
Yeah.
It's like looking at your palm. It's like seeing how much life you have left.
The rate is more important. The rate of shrinkage is
the
more
degradation
important. But
rate,
Brian Johnson, he's been checking his. He's a whole bunch of...
Who's that?
He's an anti-aging kind of guru who does tests on himself. You don't know about Brian Johnson?
I don't think so.
Oh my gosh, he's probably the most...
Is he the singer from AC/DC?
No, he's the most famous anti-aging... I don't know how you don't know about Brian Johnson.
Brian Johnson.
It's called Blueprint.
Back in Black.
Brian Johnson is like the single most important
What's his
anti-aging...
Instagram?
Brian Johnson.
Okay.
He's the most
Let's look him up.
Single most important
Brian
anti-aging...
Johnson TV. Okay. Brian Johnson movement.
Brian movement. Brian movement.
This one?
Yeah.
Brian, this guy? 84,000?
No, that's not him. Sorry, go back.
Sorry, Brian movement. Not
Millions. You. Brian Johnson. Where is he?
63K.
No, that's not him. Scroll down.
191.
Wait.
Yeah, I knew it.
No, that's not
Singer
him.
from AC/DC.
That's a different guy.
Brian Johnson.
Go back. Scroll down.
Look, fine.
There's nobody else there? Longevity. See that one that says longevity? Second one. The second thing down. Number 2. Right there.
Yelling at me, Dan.
This guy.
Oh, yeah. Dude, this guy. Yes, he was on the Kardashian show.
Yeah.
He was on the show. I saw him. He looks like he's
Brian Johnson.
AI.
Yeah.
He's AI derived.
I went to his conference, his little Don't Die conference
Oh,
in
yeah?
LA. It was very good.
Tell me about that. So this
Learned about
is
how not
this
to
is
die.
longevity. So this is anti-aging probably
He
goes
doesn't
along
believe
with
we're
that.
going to die. He believes we're going to live forever.
Well, I believe that too, but I have a different reason. Do you want to know my theory?
Our brains will just go into AI and they'll exist forever. Yeah, I mean, I've heard it before. I don't believe it. It's nonsense.
It's
I think-
uploading. That's what all of this is this is documenting human interaction so it can be uploaded to the AI to get a profile. And then eventually, when I was asking you earlier,
our brains will exist in another place.
Yeah.
Well, they already do.
So
I mean,
they can,
I have
they can
an
stimulate
AI,
the simulation that way.
I have a
It's
AI
just it's a neural
chatbot.
segment. A neural signal is the same as Nintendo. When you go do 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 do, and then it goes on. It's 8 bits. It's the same exact signal from the electrical
Yeah, of
current, which
course.
is the same one in our brain. So why is that weird? It's
No.
kinda weird. It's not
But I
weird.
have an AI chatbot that I had read all my videos.
Why is it the same signal in our brain as the signal on Super Mario?
Because that's
Brothers?
electricity. That's how it works. It's
Exactly.
electricity.
So that's why that's the portal. You just need a portal.
Well,
which
they're
Elon
working on
Musk
a
is
Neuralink.
working.
Yeah, it's
Exactly.
done.
So what I want to think about and what I've been thinking about lately is regenerative synthetics or integrative synthetics, ways that we can use AI to develop new synthetic materials that will integrate with biology. And so
like it.
then we can use this kind of crossover between a new synthetic material that integrates, like metal and bone is awesome. Like there's some things that are really good with tissue, like they ingrow really well. And if you have some kind of trabecular structure, meaning like these sizes, 400 nanometers, and they're adequately randomly spaced apart, the bone ingrows like crazy. And that's biology integrating with material sciences. And so then if you have this link between metal and bone, and then you have metal, and then you can have some kind of electrical signal, which metal conducts electricity, and then there's some kind of way that you can link electrical signals then to our biological signals. You can then have these like portals. So with synthetic technology, you may be able to develop new synthetic technology that integrates at a micro or nano level with different like structures like elastin or collagen, and has these like cofactors that is a synthetic material that at the molecular level will then be fine, and then the body will say, oh yeah, this is fine, and it won't reject it. But then that new material will then have a way that it could get connected to a full neural network of ChatGPT or the whole internet. Because then you have this giant knowledge base of whatever you want to have input, and you make an algorithm and some kind of like software program that says like, I want an arm that goes, and now you have a Luke Skywalker arm in real life that actually works. Because
yeah, they're working on that.
yeah, but we have it, right? We already have that. We have Luke Skywalker arms, but they're big and they're metal and they go and they crush things, So it's like it doesn't work right. But like the guys
They're training them better now, and there's way better devices.
it's better and better and better, but that's what I'm saying. So the direction of that is this massive concept of either what we've been talking about for most of the podcast has been biologics. It's been kind of understanding what's already here in our biological world. And then there's this whole realm that people think of technology. And then how those two fields interact may fully replace a lot of biology. So you're a tissue specialist and you kind of understand how the body and how, injury happens and how you can optimize outcomes in terms of like regenerative potential to get and restore anatomy, which is a beautiful thing. But there's this whole field of understanding where technology will then integrate with our biology, and that is this different portal that we're only so good as our anatomy. And are we ever going to evolve to creatures that have these massive brains or can have telekinesis? And maybe there's some potential with that, but at the rate of evolution, we are going to have to be here for a very long time, and it's not going to be in our lifetime. But what will be in our lifetime, or maybe our kids' lifetime, is integrative biotechnology. What do you think about that?
100%.
It's cool, right?
Yeah, no, I think that we already have it in some regards. Like think about Meta glasses, or
those are cool. I use those to record surgeries. And
you
stuff.
can see surgery, and you can signal to it, and then it can read back to you, and it can send you a teleprompter, or it can tell you have a phone call coming or a text message, right? So, or you can look at a product in a store and say, is this what I want? Is this healthy? Is this safe for me to take? Does this match with my allergies? So it can help you. If you're blind, it can translate the world to you in a way that no other device can.
Yeah.
What am I looking at right now? Oh, you're looking at Duke Ellington's record. You can put it on the machine in front of you. It's 2 centimeters to your left.
I used to do spinal cord research in rats that couldn't walk. You know, and so it's kind of like you would stimulate them and get them to move their legs,
the leg to
and
move.
Get those signals going.
I think you're right that the body's going to interface for the information to come from outside to in, but it's also going to interface in ways where disruptive signals can change the way the body moves. Yes. So like affecting paralysis and other conditions where we can intervene early and retrieve functionality. But I think it's also going to improve quality of life in many regards for patients because of accessibility. So we've always had issues with accessibility in people that have handicaps. Or
making it cheap
disabled.
and light and works well, and then a lot of surgeons can do it. It's a whole new field.
Like
it may be a whole new field of surgery, dude. Because if you know anatomy, I'm a shoulder specialist. If anybody needs a whole new shoulder area limb of this regenerative, exactly.
Yeah. But think about
they're going to come to us with our understanding of anatomy.
Think outside of that.
Like Elon Musk should be coming to us. I'm sure he's talking to neurosurgeons, but eventually he's going to talk to plastic surgeons about aesthetics. He's going to talk about shoulder specialists about how shoulders work, because I'm the specialist. I know how shoulders work. And hip and knee guys like Sean Roget at Cedars, or multiple people who have been doing this for a long time. They really understand how joints work for humans.
But think outside of surgery. Think about like a little kid.
But we're specialists at joint movement, and
I agree.
We're specialists at understanding humans.
I'm not disagreeing with that. But
AI is going to want to know how humans think, they work, what's inside, how like we interact with each other.
They want to mimic the behaviors. But I'm not talking
they're trying
about
to understand us.
I'm not talking about accessibility like surgery. I'm talking about accessibility to our environment. So think of a kid in Nepal who's like living in a shitty, situation in a world that has not created accessibility. Like in America, we have curbs where your wheelchair can go up and down because there's laws about that protect the accessibility.
He's going to be stuck in his house, or he's going to be.
He's stuck in his house. There's no road. He doesn't have a car. But now all of a sudden, and he's blind. All of a sudden, you just need a $300 pair of glasses, and guess what? You just opened the world up to this person.
The internet did that to a lot of people.
Well,
and
broadband
internet,
right? Accessibility everywhere, and it's not always a good thing because knowledge can be manipulated and changed, and perception can be weird. But just having accessibility for people around the world that live in environments where there's no accessibility built in, having one little device that could just change the way that they live. I mean, that's amazing. So I think that like when we talk about devices and biointegrating them, I would say think about the people around the world that are going to benefit from these inexpensive, solutions.
So you're not scared about it?
No, I'm not scared about it.
Some people are scared about it.
Yeah,
my mom told me not to get chipped. She's like, if they are trying to chip you, Mikey, don't take the chip. I said, Mom, don't worry, I'm not going to get chipped.
Fear comes from ignorance.
Unless it's a good chip.
Fear comes from ignorance.
I'm just kidding, Mom.
Mom,
I will not get chipped, okay?
Fear comes
Are you going to get chipped?
Yeah, 100%. Fear comes from ignorance. If you're ignorant, you're afraid. If you're
don't get chipped.
Knowledgeable, you're not afraid because
the chip might be really good though. Maybe an external chip though, something that can. I'm into portals, so if there's some kind of like access point, and that's really what I think Neuralink is some kind of access point. Right?
I mean, dude, I'm chipped right now. I've got an Aura ring on. It's testing my biomechanical markers. It's looking at sleep. Yeah. It's looking at my stress right now.
Same thing with your phone. You're a cyborg, right? Yeah.
You're already chipped.
We're just having
They're
to
listening to everything that we're saying right now. There's
AI
AI listening to what we're saying right now.
Constantly.
Yeah. So when you say, hey, you're afraid of getting chipped, I'm like, what? Dude, if you think that
that's how I feel.
You're already past that point.
Just dive in.
If you don't think you're already being,
your profile's out there, bro.
It's out there.
35,000 people.
Dude, I created an AI chatbot. I had it read my Instagram, my YouTube, and my TikTok, and now it talks like me.
It's cool.
It sends people videos.
Dude, you can be creative with AI. That's what I like about it.
It's amazing.
It's amazing. It's kind of like it's this useful tool. Me too. It's a part of my life now. I use it every day. It's replaced Google. I just look everything up on ChatGPT.
I mean, I still use a lot of Google, but
I still compose myself. Yeah. So, what's interesting is it kind of outsources.
It's good for feedback, editorial feedback.
Yeah, like a sounding board, right? It's like, hey, this or that, and then it gives you the structure. Hey, give me an outline. So I use it a lot for outline or for sounding board. And then what I'll do is I'll outsource a lot of things too. It's like, if I want to make a table, make me a table on this. Send me a response. And then it's like, okay, I always then copy and paste and then edit it and to make it mine, because
you also have to check the sources because it makes up sources a lot.
Yeah, I use Perplexity for that. And the other thing is really cool is deep research. Do you know about deep research?
I use deep research all the time.
I did that on you. I got a profile, so I know so much about you.
Yeah.
Do you want to see your profile?
Yeah. Does it say I'm handsome?
Did you look it up?
Is it a lie?
It talked about your social profile. It talked about your. I did it on ChatGPT.
I like it. I like a lot of the different.
It's on my phone.
If you go on ChatGPT and you look at different GPTs, it'll pull up like.
What's the best one? What's the best GPT?
I mean,
GPT on ChatGPT, because I've been messing with it to try to figure out like what, because it says to explore them.
Yeah, explore the GPTs.
Yeah, what is the best one for that? Let me look at them.
Well, there's different things. So like if you go to explore,
but ones that you're a cool guy that does cool things.
Yeah, so I like the video editor that's on there, Sora. But if you
camera note,
it's okay. So I like
Sora.
Yeah, Sora. I don't know why that's not on the top of yours. But
that's what I'm saying. Maybe I don't have it set up right.
Yeah,
I don't know the best GPTs.
We've got an interesting slow connection.
Should be working. Let's see. This is the GPTs.
Yeah. So
what's a good one? Sora.
Well, it depends on what you want. But see, it's telling you.
But like, tell me the ones that you use for what do you use? Like, because you can't look at porn on this.
No.
It won't let you. So you're like, okay, I guess I got to be productive.
No, I use PDF converters. I use the
AI PDF drive.
I use image generators
to make images like figures.
Yeah. I'll use
Write for Me.
No, I don't use Write for Me. Sometimes
research stuff though. What do you use for research? Like if you want to look at papers or like concepts.
I'm still kind of old school at looking for papers.
PubMed, right?
I go to PubMed,
Me too,
But if I'm going to look for if I want to create a presentation, there's some presentation.
What's the one you use for presentations? Because that's one I have not been able to figure that out.
So type in the
like
search.
PPT, PowerPoints. I mean.
Yeah, presentations, and then enter.
Yeah, it's not searching very well. Oh, there you go. Now it is.
Slide Maker.
Just Slide Maker?
Yeah, I've done Presentia.
Because I've used that and it's like a white background.
It's not as good. The Canva AI is pretty good.
Have you used any that are good where you say like, oh, that's pretty good?
Canva AI is pretty good.
AI.
Yeah.
Because I make a lot of talks still, but I have a lot of talks. So, and I like making talks.
Yeah, I give,
But I also like to have like a starting block. Like just give me something to work on.
I like to start and do it myself and then send it in and have it critique it.
Oh, okay.
So I'll
that's
say
a good
make
idea.
it more powerful.
Oh,
or
that's a
I'll
good
say
idea.
take
it some
the language and make the language more
less wordy or
consumable.
something.
Yeah, less verbose, but more consumable in a room. I'll say what the talk is for. Like I have a talk coming out that's a 4-minute talk next week on the hot topics panel at the aesthetic meeting. And in the thing, I sent it like 12 slides and I said, make this like high impact and really give me some lines that are going to like engage the people that are sitting in the crowd.
Oh, that's cool.
And then it like says, okay, here you go. And then I say, now make it sound more like me based off of my language learning models.
Yeah.
And then I say, now here's the crowd. It's all plastic surgeons. There's 1,000 of them, board certified. Make it relevant to them.
Yes.
And you just keep training it, and it hones the message.
How long have you been doing that? Where you've been kind of like working with these models? Would you say months or like?
Yeah, 6 to 9 months realistically.
Same with me. I think about the same time frame. I saw how powerful of a tool it was. And so what I found was if you don't train it well, it's kind of like having a dog.
You have to be mean to it a little bit.
Yeah, you got to kind of just don't worry about its feelings.
Yep.
Just be like, you're not doing it right. This is what I want.
Do this. Don't
say
do
no.
that.
And, and what's interesting is I've talked to a lot of people about their interaction with these models. And here, this is your profile right here. This is dude, look how long this is. I haven't seen a lot of it.
Oh my gosh, this is so long.
It's crazy long. And I haven't seen a lot, but this is pretty comprehensive. I haven't seen a lot of people who say like, oh yeah, like I use it and how your response was, and like for people who are high level or who are looking for efficiency and looking to really outsource because they're just so busy or they're, constantly trying to change and improve. It is such an insanely valuable tool for me that I was surprised to see other people not engaging with it more, or they're like worried about the cost or something. It's like pretty small amount. But in fact, I was trying different models out to kind of compare them like Perplexity and Gemini. One of my patients, her husband is one of the engineers on Gemini. Mm-hmm. And pretty high up there guy with Facebook. And, so he was kind of talking to me about it, but he's just like a normal guy. And these kind of codes are written by normal people, and it's looking at kind
thoughtful, normal people.
Yeah, very, very thoughtful. But they understand like it's just this like it's kind of it's a way to interact with code, and because I didn't really understand how computers work to like a coding sense, it's really helped me understand like what types of ways you can engage with these models that are dependent and they do remember about you, and the more you can kind of give it about specific things that you're looking for, you can start to get a more precise and sometimes better version of what you would have made on your own, because it has the things like the best of you, and then you're like, oh yeah, I didn't think about that. And it give me a more like ways that make this pop or make it viral, or you're like, oh yeah, that's a great idea. It's like where did these ideas come from? If you just say, hey, give me a good idea, it's like
it's not going to do it.
It's not very relevant. But if you prime it and you kind of tailor it, like you just said, and the guy from ChatGPT, I forget his name, the head guy, he has these like instructionals. Sam Altman. Is that Sam Altman?
Yeah.
So that guy, he kind of gives these instructionals on YouTube about like how to train the model better. And so
you
super
have to be
nerdy
very
stuff.
specific, and you have to iterate it.
Yeah.
So it's interesting because the more that you ask it the question, the more that you refine your own answer.
It gets you thinking about the
it
concept,
gets you thinking
topic
about
too.
Who is my audience? What do they want to hear?
Yeah.
Why is this interesting as a topic?
Yeah.
And so in a way, you training it is it training you into like refining your own search. And then when it gives you back an answer and you modify the answer, or you say this is good or this is not good, you're actually having to recognize that your own question was flawed in the first place.
Right.
So if the response is not good, it's because the question was wrong.
Right.
And I think that's the beauty. And
I'll be like, I'll say, tell me about reverse shoulders. And
Well,
it's kind of like,
nothing.
I don't
Yeah.
need to know about this.
But that ties it back to the
But
concept.
if I'm looking for, help me devise a research topic on reverse shoulders and complicate, it's like the more specific, and then it's, and then it pulls up a lot of stuff that I'm like, oh, there's missing parts in the literature that would be very useful, something that I could publish
That
on.
ties back to what we talked about at the very beginning, which is asking the questions what differentiates good surgeons from not good surgeons. The same concept here with ChatGPT is that the question is the most important part of the process, and asking the right questions is how you engage the software in the right way. So I think the best users of ChatGPT are those who are the most kind of inquisitive. So it's actually interesting because the process of ChatGPT training itself is highly biased and highly specialized and highly focused on the most inquisitive of the minds in America today. Most people that are using ChatGPT are not using it to say, where's the laundry machine? Or how do I turn it on?
Right.
They're using it to say something like, in reverse total shoulder in the year of 2024, which articles really highlighted the importance of technique in suture placement or suture barb placement?
What are the controversies?
And then all of a sudden it's like, holy shit, we've got this deep learning based off of the right questions in the right subspecialties in the right scientific domains. So it's actually kind of like cheating the system. Having a super good tool for education, it's like it is bypassing that. It is the education that's happening to the machine and to ourselves on that platform is so much better than the basic Google search.
Yeah, and it's more well-rounded because the Google search brings you to pages, but this gives you direct information.
And the Google algorithm has to be trained by a human.
Yeah, you still have to pick.
And the Google algorithm looks for these markers of expertise, like total number of links to academic places. The way that Google is designed for SEO is for marketing standpoints. It's for improving marketing. So Google is designed to say, who's the industry leader in this specialty? Who's the industry leader in this product? How do we find them? How do we know their leader? How do we know their product is good? Whereas the industry leader, or what ChatGPT is doing, is saying, who has the right answer to this question? And if they do have the right answer to this question, how do we frame it in a way that it makes sense to the public or the general population more than once? So I think that's the key thing here, is that the difference between Google and ChatGPT is Google is looking for the answer to a question that's really tied to a monetary value. It's really stimulating industry sales and marketing, and they sell ads. That's how they make money. Whereas ChatGPT is really, how do we answer the right question? How do we say it in the right way? And how do we connect the dots in education?
Well, I'm sure they still like making money too.
It's a nonprofit organization.
Well, what is that? What does nonprofit mean?
Well, that means they don't make money, but that they don't try to generate money as their main business model.
Right.
But Altman they've been arguing about this. This is what's in the news right now, is that they've been arguing about whether or not it should be allowed to become a for-profit enterprise. And Elon Musk is really fighting, because the reason he laid off of AI was he said they're going to be nonprofit, and now they're trying to make money. He's like, whoa. If you guys want to go become a profit-based entity, now we got some problems, right? Because
it changes the
dynamic, and they don't want that. I mean, I think it's better as a nonprofit entity because it's open access, it's open resource, it's open AI, and it leads itself to answer questions, and it's beautiful the way we're using it right now. But the minute that you turn it into a profit margin, if somebody says, who's the best plastic surgeon in America, ChatGPT is going to have $1 associated with that, and they're going to say, do you want to be the best plastic surgeon in America, Dr. Gould? Pay us $100 a month, right? And that's when you're going to run it. But right now, when you ask it, hey, Dan Gould's credentials credentials, tell me about him. It tells you everything. And you can pull
You
mine
saw the
up.
profile. It seemed
Take that
pretty
profile.
unbiased. You know,
Yeah.
it was like a scourge of the
Like
internet.
it even found my Warren Garner award.
I was going to
like
bring
first
that up,
resident,
Dr.
yeah.
Garner.
So, it's just a unique way for the system to be able to look at you in a non-biased way. And you could probably use it and say, compare Dr. Gould's achievements to every other plastic surgeon in America. Where does he lie in terms of percentage?
I did that.
And what did it say?
So you're pretty good.
Yeah, pretty good. Yeah, but
Said you're a rising young star,
here's the problem.
which you are.
In America, if you're looking for a
But
plastic
you're already
surgeon,
a star. And you're
all you
rising.
have is their website and before and after, so you don't know if you're actually getting a good surgeon. But this is a good way to validate it.
Prolific researcher, pioneer in crowdsourcing.
Handsome man.
Handsome, influential. But I mean, all these things are true. So, it's kind of one of these things where I was, because I looked at myself too, and, it's kind of, it gives you this, I was like, are there any controversies? Are there any, problems with certain people? And, it's pretty like positive. And I think because it's mostly like, what does your profile look like on the internet?
Yeah.
And if you have a positive profile overall, things are mostly pretty good. But it even talked about any negative reviews I had, so it seemed pretty unbiased. And I knew some of those things with regards to, if there's anything that anybody ever says, but it says the majority of overwhelming, feedback is very, extremely positive, which is true.
You need to have some positive and some negative because no one has
nobody's
negative.
right. I see 5.0 out of 5 and I'm like, I don't believe it.
Well, interestingly enough, I had like one bad review and I was stressing about it.
It's
and
okay.
The
It's
review,
like not everybody's always happy all the time.
well, so I was I was at dinner with my friends that are plastic surgeons, and this lady, she was mad because I referred her. She wanted a surgery that I don't perform, and I referred her to another surgeon. It was very expensive. It's like $200,000 to have the surgery performed, and she was pissed about the price. And I said, "Look, I don't control the price of other surgeons. Regardless, I saw that review and I responded to it and said that the doctor doesn't control the price of the other surgeons' surgeries,
Right.
and if you want
But
a
you
surgery he doesn't
responded.
perform, yeah." But then. I was at dinner and my friend was telling me, he's like, you needed this. And I was like, why? He's like, because you had like 75 5-star reviews that are ridiculous. Like they're like 5 pages long. It almost looks fake. Like you
Right.
need to have some negative
Sure.
feedback. Otherwise it's not real. It
The
can't be
wait
possible.
lines are too long to see Dr. Gould. It's like,
Right.
well,
Well,
sometimes it's like that.
But
'cause
then
it's realistic.
But if I'm honest with you, everyone has unhappy patients. I've had unhappy patients.
And that was just joking, by the way. That's not real.
The wait lines are too long.
They are too long.
6 months. 6 months. But I would
But-
say, everyone has unhappy, especially in cosmetic surgery. And it's really not whether or not you have unhappy patients, because everyone has some unhappy patients. Everyone
Always,
has
yeah, of course.
complications. It's how you deal with them.
It's
and how you
interacting
deal
with people.
It's how you deal with those patients.
Yeah.
Because if they're really pissed, they're going to say something really bad about you.
Yeah.
If they're pissed, but then you fix the problem, they're not going to say something bad about you, and you're going to fix the problem, and they're going to be ultimately happy.
Sure.
So really what determines good reviews from bad reviews is how much the doctor wants to spend in terms of time with the patient.
Yeah.
And so I spend a lot of time with the patients, and generally speaking, if a patient's unhappy, I can fix the problem.
Sure.
But if you're a doctor and you don't have unhappy patients, that just means you're not listening to your patients.
That's right.
Or you're just discharging them immediately and never seeing them again.
Yeah. And everything's perfect. I have no problems. It's like, well,
Opposite. I would say that most of us have
I
problems.
look more detailed at my problems now, and things that I thought.
The more you
could
analyze,
make
the
it
more you
better.
see.
Yeah.
And I think I was at a conference with the best facial plastic surgeons in the world, and we were talking about surgery, and I said, what do you think your average percentage correction is of people's problems? And we all unanimously agreed 80% correction of the problem is an A. That's like a really good result. 90% is like 2 to 3 times a year. 100% never happens. Most surgeons are like 50 to 60%.
Right, I agree,
Most.
and I expect excellent results in my practice as well. And I
But 80% correction is excellent.
Yeah.
It's not a B.
Right.
That's an A, because 80% correction means we put it where it belongs,
Right.
and then biology took over. There were things we didn't have. It's not like during surgery. If I have control over where it's going to go during surgery, it will be perfect. It is perfect on the table, but then you got to heal, right?
Yeah, life gets in
and
the way.
you sneezed, or you got a hematoma
Environment.
or something
Sure.
because you got your blood pressure up because the dog attacked you or something. There's all these things that can happen, right? That we don't have control over. And if we don't acknowledge that, then we're setting ourselves up for failure, because you're gaslighting yourself into thinking that it can be perfect in every environment. It's not possible in orthopedics and plastic surgery, neurosurgery, in any surgical domain, because it's a human body. Once we have those interfaces that are non-biologic synthetics, now we're talking, because I can do a perfect result on a plastic nose, no problem, right?
Right.
But
Well, until we're cyborgs and actually integrated with the technology, we need to have specialists in plastic surgery, orthopedic surgery, vascular surgery, and all other specialties. Well, Dan Gould, it's been exceptional having you over
been
here.
great.
On
It's nice to reconnect.
on my show. I'm so glad you and I
Yeah.
could just spend time together and hang out.
that's the main reason I'm
I
here.
just really wanted to see you, and we did it for 2.5 hours.
Probably the longest we've ever done it for, outside of an operating room.
I'm just happy that I got to spend that much time with you, and hopefully we can get together soon. And you still go to clubs?
Yeah, no, not really.
You hang out a little bit?
No, I go to sleep.
Me too.
I'm in bed. If it's
Me
9
too.
o'clock, I'm in bed because sleep is the most important anti-aging tool that we have.
Yeah, sleep.
And I'm
Good
a
sleep.
very strong advocate of sleep. That's why I'm
Yeah.
wearing the Oura Ring, and I've totally changed my biometrics by dealing with sleep and diet and a few other things. So
Well, cool, man. I think this sounds like we'll have some recurring themes to have you back on for and talk about a lot of great things. And once again, man, it's you're a great friend of mine, and thanks for taking the time to make it out here and have a great discussion today.
it's just a short little hop, skip, and a drive.
All right, man. Well, that's all, folks, on the LA Shoulder Podcast.